ready, Mr. Clerk? Good morning, members of council and staff, and Happy New Year. This is the first time we've been together as a group since Christmas. Members of council, before I call for the roll call, we had an individual who had done so many great things for our community, our cities, our region, and our country, and it was sad news when we heard of the loss of Ed Broadbent. Could you please join me in a moment of silence? Thank you. Mr. Clerk, roll call, please.
Thank you, Mr. Chair. Electronic roll call is starting now.
Okay, thank you. Members of council, declarations of pecuniary interest. Online, Mr. Clerk? Seeing none. There are no statutory public meetings. We have 2 presentations and 2 delegations. We will start with presentations. 4.1, Rachel Bromberg, Executive Director of International Crisis Response Association. Good morning. Okay, our CAO will do the introduction.
Sorry, a little out of sync there. So following a council motion to explore a non-police-led mental health crisis response service from Durham Region, a staff group formed to begin this work. The group included the Social Services Department, Region of Durham Paramedic Services, Durham Region Police Services, the Community Safety and Wellbeing Group, as well as support from the Diversity, Equity and Inclusion Program in the CIO's office. An extensive community engagement process was undertaken across Durham to explore the need for a community mental health crisis response service. Overseeing development of this work was an advisory committee comprised of the chair of the Police Services Board, Lakeridge Health Mental Health and Addiction Services, the CAO's office, Region of Durham Paramedic Services, DRPS, and the Commissioner of Social Services. Today, we are pleased to present the findings and an overview of the community engagement process and findings, and I will now turn it over to Tracy Tyner-Kavanagh, the Manager of Strategic Partnerships and Priorities in the Social Services Department, to introduce the presenter. So over to you, Tracy.
Thank you. Good morning. Before I turn it over to our presentation, I'd like to take this opportunity to introduce my colleagues that have helped support this initiative, important initiative over the last several months. And we have Director Marusha Laschuk of Family Services with the Department of Social Services. Marusha, if you could stand or wave. And Commander of Community Programs and Emergency Management with the Region of Durham Paramedic Services, Jeffrey Jordison. No hiding. Thank you. I should mention that Marusha and Jeff, in partnership, oversee the Primary Care Outreach Program, also known as PCOP in our community. We have Staff Sergeant Amanda Hoover with Durham Regional Police Service. Thank you, Amanda. And joining Sergeant Hoover today is Inspector Gord Oblenis and Director Chris Bovey of Durham Region Police Services. Following the presentation today, they will all be here to answer any of your questions. I need to also acknowledge the leadership and support of our Director, Allison Hector Alexander, with the DEI program of the CAO's office and her team for helping ensure that the Durham Region Black communities had a voice and persons with disabilities in this important initiative. And I really need to acknowledge my team, if that's okay, Heather Thompson, Danielle Thibodeau, and Samantha Billingham for all their efforts. And to our presenter, Rachel Bromberg, who is joining us virtually today, I hope. Rachel is the lead consultant to the project and is the executive director of the International Crisis Response Association, ICRA, is a resource hub for communities across Canada and the United States that are developing alternative crisis response models. So she has worked closely with Toronto, Barrie, New Orleans, Rochester, Northampton, and a number of other cities to help them develop alternative crisis response models. Rachel is a member of the Toronto Police Services Board's Mental Health and Addictions Advisory Panel, the Toronto Regional Human Services and Justice Coordinating Committee, the Center for Addiction and Mental Health Constituency Council, and PeerWorks Board of Directors. Rachel is currently completing a dual degree in law and social work and has been working frontline in mental health services for over 10 years. And I now turn it over to Rachel.
Good morning, everyone, and thank you so much for having me today. So, as Tracy said, I've been working with the Commissioner's Office for about a year and a half, since summer of 2022, to lead a community engagement process and develop recommendations for the possible launch of a community mental health crisis service. So I have some slides. I'm going to walk you through the work that we've been doing here, what we've heard from the community, what international best practices say about these models, and then I'm going to leave a lot of time for questions. Okay, great. People are running slides. So like Tracy said, my name is Rachel. I'm the executive director of the International Crisis Response Association, and my organization has been the lead consultant on this project. ICRA is a resource hub for communities across Canada and the US that are building or leading alternative crisis response models. There are 112 of these models across Canada and the US as of January 2024, including Toronto, including Peel Region, including Edmonton, also including New York City, San Francisco, Chicago, Los Angeles, many cities, many regions, many smaller towns, all across Canada and the US. And there are also a number of Canadian cities that are currently in the process of developing similar services that haven't yet launched. So I'm working really closely with the city of Barrie. We are hoping to launch an alternative crisis response team later this summer. Ottawa has also been working for the past year on developing a similar model, and Thunder Bay, Lambton, and Elgin are in the early stages of developing these models. So it's a really exciting time for alternative crisis response models. I think we can go to the next slide. Okay, so since summer 2022, we have done a huge amount of work here to hear from community members and people currently doing this work, what they would like to see in a new service. As well as to get a better sense of who is already doing this work or this kind of work in Durham Region, what are the capacities and resources that do exist and that can be built on, and where are the gaps and challenges, and what would most effectively address those gaps and challenges. So we did a lot of engagement with Durham Regional Police Service. We ran a focus group with them, and we've been in touch with a number of folks within the police service to get their feedback and their support throughout this work. And I know Tracy already did, but I would really like to acknowledge Amanda Hoover for her leadership and support throughout this project on the Durham Regional Police side. She has been an invaluable resource to this project. We also did some engagement with paramedics. We did a focus group with them as well. And we worked and we received some support from Jeffrey Jordanson, who was able to provide a lot of feedback from the paramedic side for us. We engaged really closely with Lakeridge Health and with other healthcare services, as well as with community-based mental health services. We did an environmental scan that involved individual interviews with staff and leadership of a number of existing mental health services in Durham, and a full list of that can be found in the report that is attached to the staff report. We also ran 16 focus groups and a survey that received 1,426 responses from Durham residents. Some of these focus groups are virtual, some of them were in person. We partnered with different community agencies to run the focus groups in their spaces because we thought that people would feel more comfortable attending a focus group in their own communities in spaces that they were already familiar with. And we did some focus groups that were open to anyone in Durham, but we also did some focus groups for priority populations, so particularly Black communities, Indigenous communities, people with disabilities. We did a focus group with child and youth workers, and we really wanted to ensure that we were hearing the voices of many different Durham residents from many different backgrounds and life experiences. Our survey was, I think, really, really successful. Durham residents who really shared a lot of very rich, thoughtful, detailed information about their experiences and what would be most helpful to them in a new model. And I really just want to thank all the Durham residents who filled out the survey and attended our focus groups, because their information was so valuable for our work. And people had often shared very vulnerable things with us, and I really appreciate just the trust that took. So all of the survey data, or almost all of it, was qualitative information where we just asked people open-ended questions. What were their experiences like? And what are the gaps that they see in existing services, and how might a new service address these gaps? So people told us a lot of stories, and we learned a lot from that. We also really wanted to make sure we're engaging people with their own lived experience of mental health crisis and the crisis system more broadly, because those folks who have experienced it themselves are going to have really helpful feedback on what's working and what isn't and what can be improved. We also ran a focus group and really prioritized the community engagement of families of people with lived experience, because we know that families are often the ones that are calling for the person in crisis. They are often needing help, and they're often the ones that are first to notice that their loved one's behavior has changed, or maybe their loved one is hearing voices, or maybe their loved one is isolating themselves. So we really wanted to hear from families what would have helped them when they were noticing something is going on for their loved one and seeking support. And we also recognize that when your loved one is in crisis, you are also in crisis to some degree. It's very hard to watch someone who you care about who is really struggling. So we wanted to really hear about what kind of support did family members need for themselves as they were trying to support their loved ones, and what can the new service do to support that. And of course, it was also really important to us to engage with service providers who are already providing mental health or addiction support to folks in Durham region, because they're the ones already doing this work. So of course, they're going to have a sense of what are the needs, what are the resources, what can be done. And after all of that work, we prepared a final report to summarize community feedback and provide recommendations. So that is in the attachment to the staff report. And I know it's long. I did try to make the table of contents easy to sort of skim through and see what the main themes are, but I hope that you will have a chance to take a look at that if you haven't already. We can go to the next slide. So I'm just going to run through like brief summary of some of the community feedback that we received. So generally, participants identified gaps with existing services, including one of the big things that we heard a lot about was stigma related to police response. And that's not because the police themselves are doing anything wrong. It's more due to the ancillary aspects of a police response. You have, police cars, sometimes many police, maybe more than 2 police showing up, maybe 4 police, maybe 6 police officers, uniforms, handcuffs, all of the things that just come with a police response. We heard a number of stories about people who had called 911 for help, either for themselves or for their loved ones, and having a police car show up at their home, and who had identified that as embarrassing or stigmatizing or humiliating for them, because in our society, police are very strongly associated with crime and danger and bad guys and violence. So people had often said to us in focus groups or on surveys that when police showed up to respond to their mental health crisis or their loved one's mental health crisis, they felt like a criminal. They felt like a bad guy. They felt like they had done something wrong and were in trouble. And they worried that their neighbors who saw, multiple police cars showing up at their house might think that they had committed a crime or that they were violent or dangerous. So people had discussed stigma. People also discussed challenges with hospitals, particularly just long wait times, because as I think we all know, our healthcare system is underfunded. But when someone is in crisis, sitting in a hospital emergency room for many hours is not a good experience for them. So they also discussed a lack of availability of community-based services. Often people did not want to go to the hospital or to call 911, but ended up going to the hospital or calling 911 because they either didn't know about other services or the other services were just not available. Sometimes that has to do with long wait lists. Sometimes that has to do with limited hours. So a lot of services in Durham Region are available from 9 to 5, Monday to Friday, particularly mobile services. But crisis doesn't always happen Monday to Friday from 9 to 5. If it happens on the weekend, and there aren't existing services that are available and open to respond immediately on the weekend, people are going to end up in the hospital. Participants felt that services were particularly limited for youth, for North Durham residents, and for Black and Indigenous communities who are seeking culturally specific care. We asked people in the survey whether they thought Durham Region would benefit from a community mental health crisis response service. 88.4% of survey respondents and nearly all focus group participants said yes. And many participants, particularly in the survey, were very enthusiastic about the service and really strongly urged the region to launch the service, with nearly 70 respondents referring to the service as needed and many others calling it a great idea and overdue. And I included this quote from one of our survey participants who said, if we have mental health professionals as the first responders, I think we can save many lives. We can go to the next slide. So based on international best practices and based on the engagement work we've done with the community, we've developed some recommendations for what the new service could look like. So it's really important to Durham residents that the service provide rapid response mobile service. It's really important to people that the service is able to come to them. Not everyone has access to transportation to get to the service. So, particularly in North Durham, where we heard a lot about the challenges of using public transportation. And when someone is in crisis, they often don't want to go somewhere else. They want support in their own space. So being able to have a team that can respond quickly to a mental health crisis to you instead of you going to them is very important. Community residents recommended that the service be delivered in partnership with Durham community agencies. So this is the model that Toronto uses, where we have 4 different community agencies that are anchor partners for this pilot, and each of those agencies has a number of other community partners that they can refer folks to. And the benefit of that is avoiding replication of services, building on resources that already exist and expertise that already exists. And it's also important that we wouldn't want a new service to be competing for resources with existing services. We would really want to be working together with existing services to create a continuum of care for Durham residents. It's important that the service would be staffed by mental health experts, which could include a number of different roles. It could include social workers, it could include mental health nurses, it could include peer workers who have their own lived experience of mental health challenges, but also a lot of training in how to support others with mental health challenges. And it was really important to Durham residents that staff should reflect the communities they serve. And should be diverse. When people are in crisis, it's often really valuable to them to see people who are from their own communities, who share their backgrounds, who understand what they're going through, in that way. That was actually something that in the Toronto one-year evaluation of the Toronto pilot, a number of people had commented on how beneficial it was to them to see members of their own communities coming out and responding when they were in crisis. At least one pilot should be Indigenous-led. So this is something we heard a lot from Indigenous communities in our community engagement, that it's really important that there be Indigenous leadership to this rather than non-Indigenous people coming in and sort of setting up something that Indigenous people are then expected to use that is not based on their unique needs and unique cultural experiences. So Toronto has an Indigenous-led pilot that's in partnership with 3 different Indigenous-led agencies, as well as an Indigenous advisory circle, and Indigenous leadership, and an Indigenous third-party evaluator. And this program has been, doing really well, receiving really positive feedback from our community, and is becoming a best practice. So this is something that would be beneficial to incorporate in Durham as well. And the DEI office is going to be leading some additional work later this year on Indigenous community engagement and developing out what this would look like in more depth. A service should be available 24/7. Not all models initially launch with 24/7 availability, depending on the resources and funding. But it's really essential that the goal is 24/7 integration and that happens as soon as possible. The biggest challenge that we heard in Durham Region was that services are available with limited hours, and that leads people to call 911 or end up in emergency room. So if this service is only available 9 to 5, Monday to Friday, the service isn't really picking up the slack where it really needs to. We also heard a lot about accessibility. So we heard a lot about 911 and the importance of having the service accessible in some way via 911. The majority of participants thought that was important, and the reason is because 911 is the number that people know to call. And also, if the idea is to reduce some of the burden that police and hospitals are currently taking in responding to these kinds of crises, the way that those calls are coming in is 911. So it's important to have some way to divert those calls at the source. Folks also suggested that it might be beneficial to have access in multiple ways to the service. So the way that Toronto works, for example, is our service is accessible via 911, but it's also accessible via 211 and via the community agencies themselves. So 211 is actually the dispatcher for our service, and 911 their call takers receive a lot of training in how to determine whether a call is in the scope for the community crisis response service. And if it is, they do a warm transfer to 211. I'm happy to share a little bit more information about this if anyone has questions about this. It's a little bit of a complex model, but the idea with that was to create a sort of no wrong door approach. So Toronto's really trying to push people to call 211 and not call 911 to try to reduce the burden on 911, but also for people who don't know about the service or don't know what 211 is and they're calling 911, we want 911 to be able to send over those calls. And when the service first launched, more than 80% of calls were coming in through 911. As of the one-year evaluation, about 55% were coming in via 911. And we think that a large part of that was the City of Toronto has embarked on a really large advertising campaign to let people know that the best way to access the service is 211, and to tell people if you or someone you care about is in crisis, call 211. We can go to the next slide. So one of the questions that I get a lot in my work is about staff safety. It's really important to everyone that the staff on these teams are not being put in danger. And that's a question we get a lot. Aren't a lot of these calls dangerous or violent? And if we send civilian staff members by themselves, aren't they going to get hurt? So my organization has been collecting a lot of data about this from cities across Canada and the US, as well as looking at some similar models in Europe. And what we see consistently throughout all of this data is that the majority of mental health crisis calls are nonviolent, do not pose safety risks to staff. So we've actually looked at a study from Ontario that was done a few years ago that looked at 911 call data. And that study showed that more than 80%, I think the number was 84%, of mental health related 911 calls are nonviolent. Obviously, if a call is violent, we are not sending a civilian-led team to it. Obviously, that you would be sending police to that. If someone has a loaded gun, we're sending police to that. We're not sending civilian crisis workers. So teams or cities that have these models provide a lot of training to 911 call takers or to whoever their call takers, dispatchers are, to help them assess whether a call is safe to send to the crisis team. So typically if someone has a weapon, if someone is acting violently, if there's a medical emergency, or if there's a need for police only action, so something like, entering a locked car, for example, those would be calls that would be continued to be answered by police. But what we see in Toronto and in other cities that have this model is there's a very large number of calls within specific call types. So for example, Toronto's person in crisis calls, Toronto also has a call type that's threatening suicide or self-harm. So within those call types, there is a very large number of calls that are not violent and that don't involve an immediate medical emergency that can be diverted to this team. Crisis staff will also receive extensive safety assessment and physical self-protection training, and they are taught to leave the scene if they feel unsafe. So something that we've heard a lot of, that we get questions about is, well, what if the call is initially coded wrong? What if someone calling in thinks there's no weapon or violence, but then the team gets there and there is a weapon or there is violence? The team is taught, do not stay on scene. Leave the scene, call in police as backup. That happens very rarely. I've been collecting data from a number of cities, including Toronto, about requests for police support once the team is already on the scene. And in the one-year evaluation in Toronto, we saw that this happened about 2% of the time. In other cities, it usually varies between 1% and 3% of the time. But those numbers can also be a little bit misleading because most of the time when the team is calling police for additional support, it's not because of violence or danger. It's actually because the person in crisis either does not want to engage with the crisis team, but the crisis team is still worried about this person's safety, or because the crisis team has made the determination that the person is at risk of harm to themselves or others and needs to be apprehended under the Mental Health Act, which only police are allowed to do by the legislation. Police are the only ones authorized to do that. That doesn't happen very often. In Toronto, that happens in about 2% of calls. So if we're matching that data, it looks like almost all of the calls in which police are requested by the crisis team for support are related to the person needing to go to a hospital rather than related to violence. And we've also been tracking stats, a few different other stats. So one of the stats that a number of teams track is how safe are staff feeling on the calls. So even if, violence is not actually happening, what is staff's subjective perception of how safe these calls are? There are a number of teams that track this. New Orleans tracks it. Durham, North Carolina tracks it. And they're finding numbers upward of 99% of calls staff are feeling safe. And then we've also been looking at cities that are tracking, all cities are tracking whether their staff are being injured. These numbers are either zero or negligible, very, very small. No civilian staff member on a crisis team has ever been seriously injured or killed on a call. And, we have over 100 of these models operating right now, some of them that have been operating for decades. It just hasn't happened. And when we're talking about things like minor injuries, those are typically caused by car crashes on the way to a call. The most dangerous part of the call is actually driving to the call rather than actually being on the call. Or environmental hazards, things that are not really related to clients most of the time. And again, like minor injuries, things like COVID exposure, things like getting your finger stuck in a door, things like that, things that could happen in any workplace. Next slide. So some of the benefits of alternative crisis response programs that we've seen internationally, one of the biggest benefits is conserving police resources so that police can more effectively respond to actual criminal acts. We see that police are often overstretched. There's often a lot of stuff going on that they're asked to respond to. And we also see that mental health crisis calls can be really long and can take up a lot of police time. So, for example, in Toronto, we saw we got some data from emergency rooms, and we found that on average, a mental health crisis call took about 5 hours for a police officer to respond to, and more than 2 hours of that was sitting in an emergency room. We found on average 128 minutes of sitting in an emergency room with someone who had been apprehended under the Mental Health Act. And then we know that at least 2 officers are usually responding to this. So multiply that by 2, you have 256 minutes of sitting in an emergency room with a person in crisis. And we also know that a very large proportion of people who are brought to hospital emergency rooms in mental health crisis are not actually going to be admitted to the hospital. In Durham Region, from Lakeridge Health, we see the stat that more than 70% of people who attend an emergency room in Durham Region for mental health concern are not admitted to the hospital and are sent home. So if you could see, 256 minutes that Durham police officers are spending in hospitals with someone in crisis, and 70% of that time, the person is not going to be admitted and is going to be sent home, that is not a good use of police resources. So what we saw in Toronto was in the first 6 months of the team's operation, when this team had not even fully scaled up yet and was covering about 45% of the city, the team saved Toronto police officers a projected 5,816 hours of time that they would have otherwise spent, mostly sitting in emergency rooms. So that time can be redirected towards solving crimes or doing community outreach or doing other things that are really important for police to be doing. One of the other benefits is to diverting service users away from unnecessary hospitalizations. As I just said, a large number of people who are going to the hospital in a mental health crisis are not actually receiving inpatient services there, and could better be served in the community. We also see that people are sitting in hospitals, emergency rooms for often many hours, which is not a good experience for people. We heard a lot about that in our focus groups and surveys. And we see that these models are often very successful at diverting people away from hospitals and only bringing people to hospitals who really need to be there. So in Toronto, we saw that 92% of Toronto Community Crisis Service calls were resolved without a visit to an emergency room. And of the visits to an emergency room that did take place, 3/4 of them were voluntary visits. So someone themselves said, I think I need to go to the hospital, and then the team was able to transport them there voluntarily. These kinds of services can also really reduce stigma towards mental health challenges. As I said previously, people often really associate police with violence, crime, danger, bad guys. So when people see police responding to a mental health crisis, that can really create stigma around mental illness and make people assume that, mental health challenges make someone dangerous or make someone violent. And lead to social exclusion because of those attitudes. So being able to really separate that out and show, no, a mental health crisis is a health crisis that deserves a response from health professionals is going to create a huge change over time. Service also will be able to provide rapid access to high quality mental health care for people in crisis, connect service users with resources and ongoing support to prevent them from going into crisis again, and just in general, provide client-centered holistic care that respects the dignity, autonomy, and self-determination of people in crisis. We see from other models and evaluations that have been done that people are generally having really good experiences with these models. In Toronto, we did few hundred qualitative interviews with service users and family members of service users who had access to this model, and people responded very positively about it and how they got access to resources that maybe they hadn't known about. So I think we could go to the next slide, which is just questions. If anyone has any questions for me about any of that.
Okay, thank you. We have a number of questions. First will be from Councillor Crawford.
Okay, so this is to this presentation, correct? Okay. So thank you very much for all your hard work, and it certainly sounds like an amazing program. I just have a few questions and comments. I don't know how much you personally know about Durham Region, but I know that this council has been advocating for an empath version to be implemented ideally at Whitby Shores. We currently don't have that program right now, so really hospitals are the only option when it comes to someone in a stressful situation. My first comment is around the use of 911. My understanding is 911, I mean, even from every police presentation that I've heard, is that we already have an issue with 911 not being used correctly. And so I'm just curious, for what you would have to evaluate during the time if someone was to use 911, would that be not, potentially at risk for somebody else in crisis? I'm not sure if.
Yeah, that is
she
a
can-
really good.
Okay.
Oh, hold on. Hear me?
Yeah, I can hear you.
Okay, cool. Sorry, I was figuring out how the web conferencing works. Yeah, so that's a really important question, and that's something that we have thought a lot about, and that was definitely thought a lot about when developing the Toronto model, for example. So the idea is not to add additional volume to 911. The idea is not to get people who wouldn't be calling 911 to start calling 911. The idea is for the calls that are already going to 911, which is a very large number of calls, and that currently police are responding to, that instead of police responding to those calls, a community-based crisis response service could respond to those calls. So the idea isn't to add volume, it's actually to take volume that already exists and remove that or send it, redirect it somewhere else. The way that Toronto tried to handle this was by developing 211 as the dispatcher, so that 911 calls would be sent to 211. People would be encouraged to call 211. There are some challenges with that model, just in terms of operationally, logistically sending those calls to 211 is adding some additional time. But the idea is really not to overburden 911 and to just ensure that those calls are sent to the right place.
So then under staff safety, you mentioned dispatchers would receive extensive training in assessing whether or not the call is a safety to send to the crisis team or a violent call, which would continue through answered by police. Is that through 911?
Yeah, so would be when 911 call takers receive that training. 211 also receives that training, so that if they receive a call themselves and they're asking questions about is there weapons or violence, and someone says yes, then they know that's a police call. We have to send that to 911. That doesn't happen very often, but both dispatchers do receive that training.
So then who's responsible for the training?
City of Toronto and a number of different services have been collaborating to provide that training. So the Toronto Police Communications Leadership, as well as the city staff and the anchor agencies have collaborated to provide that training.
So who would pay for that training?
The City of Toronto has allocated some funding for, I guess for this program.
Sorry, you're breaking up there.
More
Rachel,
broadly,
could you turn
but the training is a big part of that.
Rachel, could you try, the connection is not great. Can you turn off your video, please, for us? Maybe that will help.
Okay.
Thank you.
Sure. Sorry, so my answer to that question was that the City of Toronto had allocated money or funding for pilot project, and the funding included funding for communications training.
Okay, so so my question would be then, with a crisis team, kind of versus the police, if a crisis team goes in and is able to, I don't know, solve the crisis, or it turns bad, let's say it doesn't start out in a crisis situation but ends up in a crisis situation, you know, who's responsible for their safety? I mean, I think I know what the answer is to that, but like, does a crisis team, when it becomes violent, just leave?
I mean, if the call became violent, they would be calling in police for support.
But they're
Again,
already
that
there,
happens.
right?
Yeah, they're there.
So
So
then, do they
it would-
stay? Do they leave?
It would obviously depend on the situation. And again, like, there have not been circumstances, to my knowledge, and I have been collecting this data from over 100 models, where crisis team or where clients are violent towards the crisis team staff, like substantially violent in a way that would put them in danger. It hasn't happened, but I mean, as these models are rolling out in lots of different places, things will, like, if you roll a dice a number of times, you're going to get some weird, you're going to get some things that happen. So it is possible. It's not something that has happened so far. When staff show up on the scene and there is something that suggests an environmental hazard or that there might be some risk involved, typically they identify that pretty quickly and are able to disengage and call in police for backup. Often cities will give staff police radios so they have like a direct line to get immediate police assistance if they need it. That, again, happens very rarely, but they do have that available. But yeah, if there was a circumstance where initially it seemed fine and then all of a sudden someone just gets really violent, yeah, they would be calling in police for support, and police would show up and provide that support.
So
Counselor, your time, your 5 minutes is,
I got time. I got a whole bunch more questions though.
well.
Okay,
we'll-
okay.
We'll have to come back around. In committee of the whole, you can speak more
Okay.
than once.
All right, I'll go back on the list.
Okay. Counselor Lee.
Thank you, Chair. Good morning, and thank you to Ms. Bromberg for the presentation. Just a question in terms of funding. I think you answered the question, but from a costing model, is this funded through the police budget or through the municipality directly?
I guess that would be the choice of the council to determine. Typically, these programs are not usually funded by the police budget. They're typically funded by the city or region allocating additional funding to it. Sometimes they're funded by the province. Sometimes they're funded partially by the province and partially by the city. I wouldn't assume that the police budget really has much to do with this necessarily, but that's certainly up to council.
Well, you mentioned funding from the province. Is that one-time grant funding that you heard of, or is there a direct source that municipalities are able to draw from?
There is not currently a specific direct source for the province. I know that there are a number of municipalities that are in conversations with the province right now about receiving some funding to launch these models, but there isn't like an existing grant that is available. But this could change within the next year. My understanding is the province is quite interested in funding these models.
Okay, that's great to hear. So you mentioned, staff safety was one of the concerns you hear. Any negative feedback from the various pilots that you studied from Toronto? Anything that, because they were piloted, they didn't look out for the first time, that if Durham Region were to adopt this model, that we could look out for this time around?
That is a great question. I would say the access piece in terms of 911, 211, there are a lot of lessons to be learned about how to do this most efficiently. What we've heard from community in Durham is that it's really important to have some way to access through 911. Toronto chose not to make 911 the primary dispatcher, but to make 911 like able to do a warm transfer to 211. There are some benefits to that model, particularly in we're hoping over the next few years, redirecting traffic away from 911 and towards 211. But there are also some challenges in terms of increased call times, primarily because of the time that it takes to get someone's consent to transfer the call to 211 and then to actually have the wait on hold for 211 and all of this. That is adding time and stress to 911 call takers, which is not something that we want. So I think it's really important for Durham Region to consider all of the competing factors, including widespread access from multiple points, while also trying to reduce the amount of time that the amount of talk time that 911 call takers are spending.
Okay. In the report, I think it mentions around 4,200 calls were diverted outside of the Toronto Police 911 dispatch. In terms of a percentage of calls, because really, I don't know how many calls Toronto ultimately gets. Do you know roughly what the percentage of calls diverted was?
So I know that there were more than 4,000 that were diverted out of 33,000 calls. So that would be a diversion rate of about 13%. But then you also have to keep in mind that at the time, the pilot was only running in about, or the pilots were only running in about 50% of the city, as well as that a lot of that period there was still a lot of learning happening about how to most effectively divert these calls and ensuring that sufficient number of calls that were in scope were actually sent out. So 12 or 13% probably does not reflect the effective diversion rate once the model is scaled up. Some estimates from our third-party evaluators suggested that 60 to 70% of calls would be a more appropriate, or that would probably be the standard amount of diversion that would occur once the model was scaled up.
Okay. I think I have time for about one more question. It says in your report that you went to different U.S. municipalities as well, Baltimore, New Orleans, Rochester. Was there anything unique that stood out that can be applied that Toronto didn't do, that Durham could try, that sort of thing?
Oh, that's a really good question. So one of those would be around, again, access dispatch. Most US models use a direct dispatch model that doesn't involve 211 or any other third parties, where they dispatch the community crisis team similar to how they dispatch police. Their staff are usually also on police radios. They're using the police CAD system. So that's a very common. In terms of things that are less common but interesting, a number of US municipalities, rather than doing community partnerships with different community agencies, they've sort of set up a new city department that operates the crisis team. So it's basically like a fourth emergency service that is called different things in different places. So in Albuquerque, New Mexico, for example, it's called the Office of Community Safety. In Sacramento, it's called the Department of Community Response. So you have crisis workers who are hired by the city, who are able to go out and provide mental health crisis care. And that model is really interesting because, especially in a region where, for example, you have some areas that are a lot more rural and some that are a lot more urban, that is able to provide, I guess, more standardized care across the whole city.
Great. Thank you, Chair, for the questions. Thank you again for the presentation.
Thank you, Councillor Anderson.
Thank you, Rachel, for the presentation this morning. It was quite detailed. I'm just going to follow up on what Councillor Crawford asked about earlier. I get it that why the police would need to show up at most, if not all, calls that they receive. But once they determine or assess that it's a mental health issue and there's no threat to public safety or to the individual, would it make sense to, if there was a mental health, to turn it over to a mental health team? I know we have mental health nurses, but that's not enough to go around. That would free up police time, and that would free up maybe the necessity to have more police officers added. Wouldn't that be a better way to go, a better way to use resources? What are your thoughts on that?
Yeah, so that's definitely a model that exists in many municipalities. And also, when we're talking about these alternative crisis response models, many models can be directly dispatched, whether that's via 911, 211, or any other method, but also can be contacted as a secondary responder. So in Toronto, for example, over the year of the pilot or of the evaluation, we've scaled up the number of times that police are calling in this team for secondary response. So within the first 13 months of the pilot, the police called the team for secondary response 406 times. So that's about 10% of total dispatches to this team were actually the police calling for this team. And we see this in other cities too. Denver, for example, 34% of their crisis team responses are based on the police calling them. I think some of the benefit, there's certainly a benefit to that. I think it's really important that there be multiple methods for accessing service. So one of them could be secondary responder by the police, but the other thing that we see a lot is that a lot of calls come into 911 and it's pretty clear from the beginning that they are not violent, not dangerous, and that it's probably not a good use of police time to send them to respond. So having the multiple methods of access, including direct dispatch and secondary response, is what we see as the best practice internationally.
Yep, just as follow-up. That makes sense to me. That would also benefit the individual as well, to have somebody with the expertise there to assist them through this crisis. So I think that's something we should look at or should be looking at. So again, thank you so much for your presentation this morning.
Thank you. Mayor Carter.
First of all, good morning, Mr. Chair. Welcome home. I think you had a little bit of rest, so it's good to see you. So anyways, I'm going to ask our presenter to be as quick and concise as possible. What was the budget for Toronto?
I believe 10 million
$10 million.
over the,
Okay.
I think, but
But that's just your guesstimate. You were saying that 88.4% of those that were presented this concept fully supported the program. Did they fully understand all the elements when they answered that question? What was
it's hard
required
to
in
say. It
regards
was,
to be able to activate this program?
we just asked them in the survey, do you believe that the region of
Okay.
Durham would benefit from the model?
Okay. You also talked about how you dispatch people, and I'm really curious about that. You said that you want to reflect how the community is responding to these calls. So maybe you could share with me how that's done. So a call comes in. Do you ask for their ethnic background, their religious backgrounds? What do you do to make sure that the people that you're sending out reflect the individuals that are seeking help?
On an individual basis, this obviously is impossible to ensure happens every single time. But the idea is we partner with agencies to operate the model that already reflect the community. So your odds are pretty good that someone who is coming out has experience with the community and is coming from similar background.
So in our circumstance in the city of Oshawa, we have 142 nations that are represented at our colleges and universities. How would we be able to do that with this program then? If we have, that's just in one sector of our community. So how would we be able to realistically be able to accomplish that?
I don't think that we're talking about an exact match between my specific background and the specific country I come from and the person who's responding. I think in general, people want to see that the people working on this team are reflective of their communities. It doesn't need to be an exact match, but just if you see a picture of the people working on this team, what do those people look like, basically?
But you were specific when it came to First Nation.
Yes. So that's
So
a pilot that
how
is
does that
specific.
differ? How does that differ from the other 142 different nations? Especially if
Well,
we're talking about South Asian individuals, there is a real challenge and stigma that goes there, and would be very important to make sure that the right person is addressing that issue. So I don't understand how that that determination would be done.
So absolutely, South Asian communities are very important to ensure are represented and supported by this model. And Toronto has partnered with several different agencies that provide culturally specific care to South Asian communities. And actually, the Peel model has done something similar. Specifically in terms of the Indigenous-led pilot, Canada has a unique history with Indigenous peoples, and Indigenous peoples have experienced a unique colonization, things like residential schools, 60 Scoop.
I get that. I get that.
ongoing-
I get that. I get that. I'm just trying to understand how that matching would happen and how important that it was part of your presentation, that was a really important aspect, that it truly reflects the community. So I'll move on. I'm a little stuck on that, but I'll try and do my best to be able to do it. Just out of curiosity, so this is front facing, correct?
Yes.
Okay. And so is it important that if the front facing is moving forward, that the back end of it is also supported 100%? Is that my understanding? For the program to be
Absolutely.
successful? So did you say yes?
Yes.
Okay, good. So that would mean making sure that we have mental health beds and addiction beds available immediately, correct?
Yes.
Okay. So out of that $10 million in Toronto, did they also have that extension in regards to the hospital care that would be necessary to support this program?
Yes.
They
Not
did.
specifically
Okay.
hospital, because what they found is that a lot of people did not need access to hospital, but did need access to community-based crisis beds. So additional funding was allocated for those community-based crisis beds.
Okay. My time has expired, Mr. Chair. Thank you very much.
Thank you. Mayor Schumer?
Thank you very much, Mr. Chair. Through you, a lot of my questions have been addressed, but one question I do have to the presenter, and thank you for coming out with this. We have a report, of course, later in the meeting, and in that report is a response from Durham Regional Police. Have you had a chance to read that over?
Yes.
Okay. What would be your comment to, I think it's the last paragraph on page 2 of the attachment, page 129 of the overall report. I'm just curious. They speak to kind of an evaluation of the Toronto Community Crisis Service, and I'm just wondering what your comment on that evaluation may be.
Yeah, so specifically in terms of the evaluation, I think that some of the things that Durham Regional Police have suggested should be evaluated are difficult things to evaluate in the first year of a model. So it is difficult to know in the first year of a service operating whether it reduces future police contact in a longitudinal way. Like, you could only really measure that over the first few months of the service's operation. I also think that the service, a crisis response service, is not it's not going to solve every single problem that a community might have with mental health. And the Durham Regional Police are completely right when they say things like housing insecurity, food insecurity, unemployment, severe illness. Those kinds of things absolutely contribute to mental health issues in our communities. And I think Toronto has really tried to address this by allocating additional funding to bolster community resources that do try to address this. But again, like, that's not something that the City of Toronto can do on its own. There's a lot of aspects of that are under provincial funding that the province would need to fund. I do think that just because this service cannot solve every single problem doesn't mean that it can't that it can't provide good care, create good experiences for people, and reduce some of the strain that people and police are experiencing right now. There are many metrics in the Toronto evaluation that are showing really positive outcomes. For example, reducing hospitalizations, saving a very large amount of police time. And I think more importantly, our independent evaluators did a number of focus groups and surveys and individual interviews with service users and family members who spoke glowingly about the service and how beneficial it was for them, and how they had never, they'd never expected this kind of compassionate, person-centered response. So I think that even if we're not, this program is not going to solve the housing crisis. No one is suggesting that it will. But if it can provide compassionate, client-centered care to people in need at their moment of need and connect them to resources, and even if that doesn't solve everything 100% of the time, I think it's still worth doing.
Okay. With that comment at the beginning there, that it's been a year or so, and I guess something like a $10 million budget. I mean, eventually, all programs need to be evaluated. So if a year isn't good enough, after what period of time can you realistically evaluate the success of a program?
A year is good enough for many metrics. A year is not good enough to know if this service over a long period of time reduces police contact. So most people who call 911, whether they get access to police, ambulance, or the community crisis team, are not actually having a subsequent police interaction within the next year. So in order to measure whether this program reduces the likelihood of someone interacting with police again, you would need a lot larger numbers. So you can't evaluate that in the first year, but you can evaluate many other metrics that have been evaluated. And I'd really encourage you and anyone else who's interested to read the Toronto evaluation. It was, in my opinion, very well done and goes into a lot of detail about different metrics.
Okay, thank you very much.
Thank you. Second time around, Councillor Crawford.
Thank you, Mr. Chair, for letting me back in. As far as information gathered through this team, is that shared with police?
It depends. Usually the answer would be no because of PHIPAA and relevant health legislation. If police and the crisis team are on the scene at the same time, or if the crisis team is handing off the call to police, in those circumstances, some information would be shared to, like, all of the information police need to effectively do their job would be shared, but obviously personal health information would not be shared unless necessary.
So just to confirm, the majority of the training is done by police. The 911 is used by this team, but the information gathered is not shared.
So the information gathered by 911 is shared with police and not with police, but it's kept in the typical, like, the 911 database call logs, all of this about the call. But personal health information would not usually be collected and shared, and like the information once the team gets there, that would not be shared back with police.
Okay, I only have 5 minutes. So under benefits of alternative response, crisis response, it says provide rapid access to high quality mental health care for individuals in crisis. For Durham Region, what does that look like? How and where?
So that could look like a few things. So in Toronto, that looks like
No, Durham
both
Region. Durham Region.
That would really be a question that
Yeah.
would go back to our staff.
Okay.
Yes, that is also
Do
right.
Do I wait till the report, or
Wait till
is that,
the report.
yeah, okay, thank you.
Thank you. That exhausts the speakers list. Thank you very much for attending our meeting this morning.
Thank you for having me.
Members of council, I'd like a motion to alter the agenda to bring 5.1 and 5.2 forward at this time. Moved by Councillor Anderson, seconded by Councillor Kerr. On a motion to alter the agenda to bring the delegations forward, I'll call the vote. All those in favor? In opposition? Seeing none. Pardon? No, we have 4.2 is next, and then delegations. So Dr. Stone and Ms. Hall, if you'd like to come forward, please. There was an addendum sent out late yesterday. So So members of council, Dr. Stone and Ms. Hall will be presenting together, so we'll be doing a 10-minute presentation. And good morning and welcome, and when you're ready, please start.
Thank you. Can everybody hear me? Well, good morning, and thank you for having us this morning at your meeting. My name is Sheila Hall. I'm Executive Director at the Clarington Board of Trade, and I am the Community Representative for Durham on the Durham Physician Engagement Team. Over the past year, a dedicated team inclusive of local family physicians, community regional representatives, strategic staff at Lakeridge Health, the new Queen's Lakeridge Medical Program Manager, and Ontario Health have been working together to identify a strategy to address the current and growing shortage of family physicians and access to primary care in our community. In addition, our group has played an important role in supporting the development and welcoming of the new Queen's Lakeridge MD Medical School and its students. This work has been supported by the Durham Economic Development Partnership, and we want to express our gratitude and support for their support and collaboration. So, this presentation will provide insights into our work, which has included extensive research and outreach to help us understand the current landscape, the unique needs, opportunities and challenges in Durham for attracting new physicians. In addition, we have identified key strategies, reviewed models of governance, and required resources in comparison to our competing communities across the province. Wow, whoever's switching the slides, great job. On point. So this slide really shows some of the fast-paced collaborative work that has happened over the last year and a little bit. The need to attract family doctors to our community is not new for Durham or for communities across the province. I know I personally have worked on physician recruitment programs in the past, and other communities across the region have done the same thing. Today, we feel it's really important that we bring a regional lens to this work. We have a regional hospital system, and so the attraction of doctors and some of the great work that's happening in our community today lends itself to a regional lens. So the conversation regarding the need for physician recruitment program has been re-amplified during the development of the new medical school in Durham. This project was fast-paced, inclusive, and successful due to shared goals, collaboration, and innovation. I have sat around a lot of tables for supporting community development in this region over the last 23 years. And I can tell you this group that came together quickly, put all ego aside for a shared common goal. And everybody on this team holds a lot of passion. So a little timeline for you. In March 2022, I got a call from Dr. Stone saying there's this new idea being floated around. 20 new seats were assigned to Queen's University for medical training for the advancement of family medicine. Lots of conversations in theory happened. Steering committees focused on if we created this new medical school, what would it look like? Who would be the teachers? What would the curriculum look like? How can the community support? And then how do we set it up? What resources do we need from the healthcare system? Fast-tracked to September 2022, we held a health summit, and shortly after, the province announced that it was time to go, that they wanted this school up and running and the first cohort of students to be in place by 2023. So I can't even express how much work went into that, but successfully, the doors to the school opened. The first cohort of medical students started their classes early September 2023. I believe now applications are in for cohort 2024. And so this will grow by 20 medical students every year going forward. So you can see that will multiply into a whole lot of learners in our community, which provides a great opportunity. But it's not the only opportunity that we have. So starting a new program, like a physician recruitment program for the region of Durham, is quite a learning experience, especially when we have these organic opportunities in our community through the learning opportunities. So we've spent a lot of time over the last year, going out and finding out what other communities are doing so that we know what our competition is, we know what services are being offered, and we've looked at communities that have like educational facilities in them, and we've looked at communities that do not have So we've looked at both sides of that spectrum. We spent a lot of time with this first cohort. We've participated in all of their orientation week. We've surveyed them to find out what they're looking for in the community. You know, we thought we would create all these great community opportunities for them, and quickly discovered that they're really busy studying and learning. And so we need to find a balance on how we support their learning first and foremost, and how we integrate them into the community. So they've been a great resource for us. Next slide. So this is our first cohort. There was a lot of things that had to get put in place that in most post-secondary are already there. This is a brand new school, so they needed a brand new student body. They needed we've found ways to connect them to the other post-secondary institutions in the region so that they can cross-pollinate some of the services and community resources that they're looking for. And this program has caught attention, right? As I believe a week after the school opened, the Vancouver Star put an article on the front page saying, we're looking at this community in Southern Ontario that's doing this really neat new school, but it won't work in British Columbia because that's just not the way we practice medicine here. And then a couple of weeks later, Fraser University came out and said, we're going to do that. So it's captured the eyes and the hearts of a lot of people across the country. So as great as this school is and how excited we are, these students are going to be here for 6 years. And we have a lot of time to nurture them and to engage them in our Durham community. There's other opportunities that we need to make sure we don't let go of. So also within the Lakeridge Health family, we have a residency training that's been here for over a decade. These are year 1 and 2 residency trainees that come from Queen's University and are in our community for those 2 years, learning from our wonderful doctors that open the door. So if I'm going to put a plug in, when you go to your doctor and they say, do you mind seeing our resident? The answer should be yes, every time. So there's 9 residents year 1, 9 residents year 2, every year that come through our region. And I actually heard yesterday that the retention rate for this group, we call them Q-ball, that for this group is about 30% for Durham Region. And so that's a pretty high percentage, but we want to make that a little bit higher. So we want to make sure we're paying attention to the residency training program as well. In addition, there's a Rural Ontario medical program that sends resident learners from all across the province to come and work in our communities. And so we want to make sure we're connecting with them as well. And then there's 17 medical schools across Canada, 6 of them in Ontario. We need to make sure that we've got our eyes on those students and learners and getting to them before they make their decision on where they want to stay. And so last and certainly not least, we have a lot of Canadians that are being trained abroad, Ireland, the UK, Australia, the United States. And regulations have been eased a little bit on repatriating these learners and getting them back to Canada. And so it's important for Durham to make sure that we get our eyes on them and make sure that they are ready to come back. With that, I'm going to pass it over to Dr. Stone to share a little bit about the numbers and why we need to do this work.
Thanks, Sheila, and good morning, everyone. Chair Henry, CAO Baxter Trehar, the mayors, councillors, and staff. It's nice to be here and be able to talk to you about this. I think one of my jobs was to describe the burning platform. I don't know how much I need to do that, but I will give you a bit of information about that. What I'll just say about the information Sheila gave in terms of the training that goes on here in Durham. So let me give you my background quickly. I've been a family doc here in Durham for over 31 years. I've been involved in recruitment at the local level, sort of the municipal level for many years. I've held a hospital leadership role, which I just retired from a year ago. And I also have a leadership role for our family doctor group of 40 doctors. So I've been intimately involved in this work for a long time and have a great familiarity with it. What I will say is when it comes to the learners, there's evidence that when learners are held in the community and entwined in the community and really integrate and embed, there's a much higher likelihood they'll stay. So we certainly want to be attentive to these 20 learners who are here. And what that translates into is 20 new graduates a year from this new program starting in 2029. We already have 9 graduates a year from the 2-year family medicine residency program. And then we have these other learners who come through for like 8-week blocks. We want to capture everything we can to encourage those folks to get excited about Durham and all the communities in Durham or the communities of their choice, increase the likelihood that they're going to stay. And that's our work. So I'll just give you some of this data very quickly. So we know from the Ontario College of Family Physicians, some data collected, that as of September 2022, there were already 2.2 million Ontarians without a family doc. It's already expected to grow to 4 million by 2026. And the situation is a bit problematic because training of family docs doing comprehensive family medicine has really been a problem in this country. This is not the time to get into all the reasons why. I will tell you, though, that only 30% of folks graduating with their MD from med school are choosing family medicine first. Now, this new program that Sheila spoke about is very exciting because it's a new way of actually selecting medical students. It's as much about choosing med school and family medicine residency at the get-go. That's brand new. It's a brand new strategy. And so all these 20, we're hoping that all 20 will continue in comprehensive family medicine when they graduate. But that's still 6 years out for our first cohort. We really want to make sure, though, we do everything we can to keep as many as we can. So some other information you want to know, or I'd like to share. We know that high-quality access to primary care affects health outcomes. We just heard, a great discussion about mental health and how it is that we need to improve, strategies for mental health, especially in the emergency situation. I'll tell you that very high-quality primary care mental health will ease some of that burden as well. Now, I will also tell you, Sheila mentioned this, the reason we don't want to just focus on the folks who are here is because there's such a deficit. So we know that what happened to the College of College of Physicians and Surgeons of Ontario recently changed their policy so that folks who are trained in the 4 countries that Sheila mentioned automatically can come back and be licensed without the requirement for more training or supervision. So that's a positive. It's why we don't want to just focus on our local trainees. We need to be broad-minded in terms of how we recruit. So that's the current challenge at the Ontario level, and you know there's Canadian data as well. At the Durham level, if we go to the next slide, we already know that we have significant issues. So I'll point you kind of to the bottom line on that slide. I won't go through all the municipal issues. And at the regional level, I'll tell you that, there's something like, it's estimated, this is Ministry of Health data, something like 25% of the folks who are here who already either don't have a family doc or what we call precariously attached. What does that mean? Excuse me, my mouth is dry. So there's been a progressive migration into Durham. You all know that better than I know it. And these are folks who come from Toronto, north of Toronto, west of Toronto. We see them all the time in our clinics. Many of those folks can't let go of their family doc wherever they're coming from because they can't get a doctor here in Durham. So many of the docs who are already here in Durham, and there's estimated to be somewhere around 380 family docs in Durham, so many of them already have full practices. So it's a real challenge for folks, particularly the new folks coming to Durham to get a doc. Or if you happen to have a doc and you're here already, you're really afraid if they retire. We know that something like 100 of those doctors are already 60 plus, and are at the stage of their lives where they can start thinking about retirement. So this is an important issue. Thanks very much, Dan. I'll just take a sip of water.
It's pure vodka.
So we know how important the build out of primary care is for residents everywhere, but our focus here is Durham. Part of the reason for the Durham-wide strategy is, I can tell you, doing recruiting for a long time, when folks are thinking about staying, the docs often have a more holistic view of where they're going to live and where they're going to work. So even if there's a specific municipality like where I come from in Clarington looking to get those docs, they may or may not live in Clarington, even if they work in Clarington. Or if they live in Clarington, they may or may not work in Clarington. They may work elsewhere. I think that's why we actually want to make sure that we have the region as a strong leader in this, and bring the municipalities as a team together, not keep it separate. That was kind of part of the reason we really felt we wanted to focus at a Durham region level, so we don't lose that idea of how it is that docs actually look at communities and how they think about where they want to live and where they want to work. And we want to be competitive because we know, and Sheila mentioned this, and the report talks to it in a little more detail, that some regions in and around Ontario, particularly the Southwest, Hamilton area, are doing this very well now. We have a lot to learn. We're at the very beginning of this journey, but some are doing it very well. And we know for a fact that folks have many considerations about where they choose communities. It has to do with the quality of the career they can have there. It has to do with the life they have in that region. It has to do with what's available to their partners and children if they have children. So there's a lot that goes into this that's beyond just doctors trying to recruit other doctors. It really is a community-led effort. So now, if you go to the next slide, this is unique needs and challenges of Durham. I'll only talk about this briefly. Urban versus rural requirements. So in general, it can be more challenging for our rural communities here in Durham to recruit and retain physicians. Again, lots of reasons for that, but the point is what we need to do is we need to make sure that we are reaching far and wide for folks, and then giving them the opportunity to see all the opportunities that exist here in Durham for where they can work. Growing diversity in the community, I've seen it firsthand. I think we've all seen it. As we see the growth in the community, we see a progressive growth really in cultural diversity here. And it's great. It does mean that from a medical perspective, there's a lot for us to learn about how we meet the needs of our folks who are existing and our newcomers. Because some of their healthcare needs and some of the way that they interact with the healthcare system is different than what we might be most familiar with, including doctors in their training. I'll talk about infrastructure for physician practices. So right now, there needs to be a partnership with the work we're doing and all the different medical clinics across Durham. Sometimes there are capacity issues, and so part of the work this year is understanding where is there capacity to add doctors, and where isn't there? And what does that mean for those communities if they actually don't have the infrastructure, the offices, and so on? Because, you know, when you're a family physician working in the community, it's basically you're running a small business. So there's a lot for I think for this council to learn, and for all of us to learn about what does the interaction mean as we support this effort to recruit and retain docs. I've talked about some of the other things already about family considerations. I will mention something about collaborative work environment. So most physicians who are trained here in Ontario are actually trained in a team-based environment. They call family health teams. Only 30% of Ontarians actually have a doctor who's attached to a team. The rest don't. There are only 2 teams here in Durham. So even less than that, probably 10% of people in Durham are attached to a team. But family health teams are being looked at as the way of the future of delivering primary care. It actually helps when you think about family docs as a limited resource, and health human resource is such a problem. When you build out the team, there are different ways to interact with and access primary care. I say that because what's happening right now is we have limited number of teams. It does influence the doc's decision about where they work. The province is talking about, and this is mainly, and you know, as a provincial jurisdiction, they're talking about a build out of these teams and making them bigger, and creating more of them. Now, I think what I would look for from this, from the folks in this room, is to make sure you understand that, and happy to discuss this with you in more detail, to hold our good friends at the province accountable to make sure those teams get built. Without them, we will still have a progressively limited access to primary care, a big problem. So this is all of our work, and your help is needed to make sure that what the province is talking about and committing to this team-based medicine, in fact, gets delivered. So I'll leave that topic for now, but I just wanted to flag that for you. And next slide. I just talked about part 1 of this slide. Part 2 of this slide is really that, I think most might be familiar about the federal health transfer. Some of the provinces have already closed the deal with this transfer. Ontario hasn't yet. I think that the amount of money that's being talked about is $8 billion over 10 years. And we know that there are 4 pillars to that transfer, and one of them is primary care and the build out of primary care teams. I only flag that for you because, again, every one of us has an interest in making sure that this work progresses and proceeds, even as we try to recruit family docs. What it also means, if we're successful here, is that there will be a need beyond the need to find more family doctors, to find other healthcare team members as this build happens. So that's just for future discussion. I don't think that's a topic we want to focus on today. We really want to just get going in 2024 to build out the recruitment strategy for family docs specifically. So next slide. So really, we know that that it's possible to be successful in recruitment, and regions have already demonstrated this here in Ontario. This is really a new conversation for Durham. I think you've already seen the information that was provided in the report about the initial funding and the funding requests. But really what we're looking for today is to gain your support for this idea of building a regional recruitment strategy, and would welcome any questions from you regarding this effort. So thank you.
Thank you. We have a long list. We'll start with Mayor Carter.
Thank you once again, Mr. Chair. Good morning, Dr. Stone. It's good to see you, and I wish you and your family all the best in 24. Ms. Hall, always a pleasure to be able to see you. I'm going to be very quick about this. And this is a unique program that's happening at this particular moment. How important is it at this moment that we actually put a plan in place so that we have an opportunity to be able to secure those that are coming here to be trained?
So thank you, Mayor Carter. So we need a plan and a structure in place now because the need is so urgent today for our residents here in Durham. I've already described almost 25% of Durham residents lack access. So we need to get this recruitment process, highly effective process, up and running. You know, the typical cycle for new graduates, because it's mainly new graduates we're talking, is that they finish their training in around June. Sometimes that's staggered, but it's mainly June. And so right now they're starting to look for where their careers are going to take them come summer or September. So this is something that we need to really get going now, not leaving it for later.
Okay. The second part is my understanding is for a lot of family docs, they're going to have to set up a shingle and a location to be able to welcome part of that 25% of Durham residents that don't have a family doc. So is it advisable that we engage partners outside of the healthcare industry to be able to help us provide those spaces and get them ready to be able to welcome family docs in Durham Region? Should that be part of the strategy of this program?
It is part of the strategy, and
Okay.
it will be. This is a real community effort. It includes the business community.
Yeah.
What the work we want to do this year is to have a full understanding of what the capacity looks like in municipalities all across this region, and then understand what additional build is needed.
Okay. And I'm glad to hear that, because I know that there's been some interest by developers saying we would love to be able to have them within our intense communities. We can provide the space, we'll do the build out. We just need the family doc to be here, believe it or not. So I think that's a really good sign, because that's one of the aspects that a new family doc, not being a business person, but being a medical profession, could have the opportunity to be able to do that. In your opinion, based upon the program that we've got running at this particular time, what rate of success do you think that we have reasonably to be able to achieve?
I think that the data historically describes around 50%.
50?
Yeah,
That's-
because you know, the program itself, it's a Queens program, and Queens is, as you know, consider themselves provincial and national in scope. So folks come from far and wide, and then the question is, what proportion of them will then, you know, build their lives here in Durham, and then stay? So I would target something like that.
Okay, great. Dr. Stone, thank you very much, and Sheila, thank you very much for your presentation today. Mr. Chair, thank you for the opportunity to ask those questions.
Thank you, Councillor Anderson.
Thank you, Chair, and thank you, Dr. Stone and Sheila, for the presentation, and thank you for all you do for our communities, not just Clarington, but Durham Region as a whole. I know you have done recruitment in the past, and you're now doing it again. I guess we lose doctors through retirement, they leave for elsewhere, etc. When a doctor chose to leave, do you have some sort of exit interview to find out why they're leaving?
I can only speak to the group of 40 physicians that I work with closely. I can't describe what happens all across the region. It's a good question, though. And within you know, my own experience, including when I was in my hospital leadership role, there are a number of reasons why. It often, most often, is due to family considerations, I would say. Sometimes there are other career opportunities that pull people in a different direction, but those are the ones that I see the most.
Okay. Through the chair, I know I believe it's yourself or Sheila mentioned that our retention rate is about 30%. I stand corrected. And we want that increased. What can we do? So we bring them here, which is the initiative you're working on. What are we doing, or what are you doing extra to retain them, to make sure they stay within this community, whether it's quality of, well, you don't have much control over that. We probably do as elected to make sure the quality of life is there for their families, etc. What can you do to retain, to upgrade that?
So the 30% speaks to the 2-year training program we have right now. Just to be clear, what can we do? We need to understand what the needs are for these trainees, and we need to. I actually think what we need to do is do a great job of showcasing all of the communities we have here across Durham, including what the opportunities are for them in their life outside of medicine, which is going to be so important to where they decide to stay. In medicine, we need to understand what the opportunities are for them within their career. What are the group opportunities for them to join here in Durham? What's the infrastructure look like? I think those are the keys. Those are the things that people really are interested in when they come and they look at our community. And by and large, our biggest competition, I will tell you, is, you know, aside from how we compete with each other in Durham, which is a conversation that I think we want to be mindful of here. I see folks who are looking, you know, they have something in mind, and so they often are looking in the periphery of the GTA. And so they're looking, and so our competition are those who are similar to us, you know, similar in proximity to maybe family in Toronto, or similar in some ways. We want to understand what that looks like, because if you are from Ottawa and you're going back to Ottawa, it doesn't matter. If you are looking for a career somewhere in the GTA, it matters a great deal.
One final question, Chair. I assume you're looking at what the other communities are doing to retain doctors, or you have looked at communities that were able to retain their physicians, and maybe we can emulate some of what they're doing. I am sure are you doing that?
Yeah, and that will be the work of the recruiter and the team that gets built. So I think the focus needs to be on making sure we get that resource in place, and that, you know, there'll be a learning curve, but those are you know, that's the work effort about understanding what we need. People who live and work in the same community have a much higher likelihood of staying. We've had docs, I've seen it, who've worked here, they've lived in Toronto, and a proportion of them end up looking for work location closer to where they live, not the other way necessarily. So, but this work and what we're trying to do with this recruitment effort is build the capacity and the knowledge to do exactly what you just said.
Okay. Thank you very much. Thank you, Chair. And anything we can do to help, let us know. Thank you so much for the presentation.
So, members of council, I'm going to ask that your questions be succinct. We have to do item 4.2 before noon. Okay? Councillor Wu. Sorry, Councillor Wu.
Yeah, thank you through the chair, and I'll try to be succinct. Thank you very much, Dr. Stone and Sheila. Just getting back to this program that, in fact, I was very pleased to be able to present, meet and greet the students. We say this is the first one of its kind in Canada, and sort of the model. Now, 20 students, can you give me an idea of how many applied for this program, and we took 20 of the cream of the crop?
This data used to be right at my fingertips. I think in the end there were something like 3,000. 5,000. Yeah, 5,000 invitations went out, and 20 were selected.
Okay, so over the course of time, we'll build every year. We'll bring in 20 new students, if you want to call it that.
20 new first-year students, so that in 6 years we'll be graduating 20 per year.
Right. Now, and again, if I can speak to the shortage that we have. Right now, we have about, is it 377 or almost 400 physicians, primary care physicians in Ontario?
No, that's in Durham.
Okay, sorry, my apology, you're right. And you're looking at, what is it about, and you had the statistic up there, about 100 Durham family physicians are of the age of 60 or nearing retirement. But there's no such thing as a set date for retirement. Some can practice until whenever.
I hope not.
Okay. Now, if I can, and again, what we're looking at here in Durham is something that we're working together rather than, let's say, trying to outbid somebody or poach somebody. We're trying to, work together collaboratively.
Yeah, I mean, from my lens, ideally, we want to collaborate as a region, and we want to, as best we can, standardize incentives. Their incentives will play a role in this. It's only a small piece of what goes into real recruitment and retention. But where incentives are at play, it is good to try to standardize as much as possible to limit internal competition.
Right. Well, when I look at Sheila Hall, I think about 10 years ago, Clarington, we
Counselor,
did have.
I hate to do this, but we are very short on time, so questions, please.
Okay, yeah, this is about incentivizing, and we did incentivize, and it was very successful. And again, I don't know if that is something too that we look at money in the pot.
I'm just going to speak very briefly. I think it's going to be a consideration that needs to be the work of this year, as opposed to giving you information today about what it needs to look like. We need to be able to understand what that looks like, and making sure we understand, this recruitment effort is so much bigger than incentives. But we know that incentives exist, already here and elsewhere. I'll only say, Councillor Wu, that it's important, but we'll continue to develop this year hopefully we launch this program.
Okay. Thank you very much. Much appreciated for all you do.
Thank you. Mayor Schumer, would you please push your request to speak? It was on. There you go. Thank you. Mayor Schumer?
Thank you very much, Mr. Chair. And I'll try to be quick. And thank you for coming out and doing this presentation. With respect to the figures that are presented on slide 8, first of all, what would be the provincial percentage as far as people without a physician?
So, pardon me, if we estimate the province is somewhere around 15 million already, that 15 million residents, then right now, as of September 2022, there were 2.2 million. It's likely 2.5 plus. So if we do the math, we would say, well, probably across the province, it's somewhere around 15%, with the anticipation that over 4 million by 2026 will be without a doctor in the province. So I think we would just do the math if we started at roughly 15 million.
Okay, and I think on a couple of occasions you mentioned, of course, that rural areas have more challenges than urban, and we've got a rather large chunk of this region which is rural. But looking at those stats, I have to, I'm Brock. It's 35.5. That's, about 45% worse than the regional average, and it's over 100% worse than our neighboring northern municipalities. So can you elaborate a little bit? I know you said you weren't going to, but can you elaborate a little bit on those challenges and why we might see such variations in the numbers?
It's always multifactorial. One of the things about very rural areas is physicians often end up working alone because there isn't a population base to have a full team. So because so much of training now is team based and we work in groups, it's a disincentive for folks to work to work alone, like it might have been 30 or 40 years ago. There are issues for folks about, when people if they've lived or trained in urban areas, sometimes they gravitate towards the services that are there. And also in more rural areas, the requirement for a family doc to do comprehensive services and as a generalist is typically larger. So you think of a family doc who's in an urban area, and you might just work in your office only. You might do other things. You might work in the hospital. You might work palliative and so on. But when you're in a rural area, you're often called upon to do all of it. The way training has gone in Ontario and in Canada, there are fewer and fewer generalists who are graduating anywhere. And that means that the pool of folks for rural areas is getting smaller too.
Okay, so what are some of the possible strategies to combat those challenges beyond the strategies for the more urban areas?
Yeah, So I don't, I'll try to be brief. I don't know how much time we have here. I know we have to get going. Part of what we're trying to do with this new the program training right here in Durham is to develop generalists. There's an understanding about what the problem is and the shortfall. So we are hoping to be better at doing exactly that kind of training here in Durham among the 20. And that's something that needs to happen more broadly, but out of scope for us.
Okay. And my last question would be, because, I've sat through meetings with specialists on doctor recruitment, with physicians themselves. What are your personal thoughts on the competition process with incentives? Because a lot of them have said that this shouldn't be happening. All it is one community after another. We start raising the stakes to the point where it's the richer communities that can afford these incentives. So what are your personal thoughts on maintaining these incentive programs with respect to bribing physicians to move to other communities?
I think the concern is fear. It's a supply and demand market, and the reality is, if you watch what's going on across many communities across Ontario already, there are some substantial incentives being offered, and that includes across the GTA. So it's why I spoke earlier about in my own opinion, the desire for us to standardize as much as we can within Durham. So we aren't competing across with each other, but we have the shared common goals. And then we'd have to decide to what extent, as we try to bring docs here, who are thinking about us in Durham or thinking about other communities, to what extent will incentives make a difference? To me, I think it's still small. There are much more important considerations about work life and family life. But it can tip the scales when you're weighing 2 or 3 communities that you view similarly. So I think it's going to be up to us working together and really trying to collaborate and build a strategy that we think is most successful. I still agree with you, though, that the most important facets of recruitment and retention are not the incentive.
Okay, thank you for your time. Thank you.
Councillor Brenner, I'm asking that you be succinct, please.
Very much. I'll just ask one simple question and ask for a simple answer. Dr. Stone, you had referenced family health teams and the need for more, and that there was only 2 in Durham region. Can you, in a very short way, identify the locations of where they exist in Durham and how you see that will benefit as well the region and also our recruitment?
One is in Pickering, one is in Scugog, and that's it for our teams. How will it benefit? It's the way of delivering healthcare. It's the way that all our trainees are trained. By and large, most of them are trained in this team-based structure. So it's what they know. It's what they've learned in terms of how you work as a team to deliver your service, and it creates an advantage for communities or for systems that have the team structure. It's better for patient care as well for lots of reasons, especially when we're so scarce on family docs, because there's lots of things that can be done to deliver a high quality care that doesn't have to be done by the doctor. It can be done by a nurse practitioner, it can be done by a social worker, it can be done by a counselor, a therapist, or a pharmacist. So it's something that we need to be mindful of, but it's I think part of your education and my education and the recruitment effort is to make sure that we advance that team structure here across Durham.
So very short then, what you do see is a role for the regional council to put pressure on the province of Ontario to increase the numbers of the family health teams.
I'm going to just say it slightly differently, which is that to make sure it remains a top priority. As the government has so many competing priorities, let's keep it high on their agenda.
Thank you, Mr. Chair. I kept it short to the point.
Thank you. Councillor McCaughey.
Thank you. I'll keep it as succinct as possible. Thank you for your presentation today. It's hard for me to reconcile that a lot of these students are my children's age, but they are. And some of them I know that are studying in Ireland. And so how is it that we can identify some of our local students that have gone off to study abroad? Do we know where they are? And are we able to tap into that as a resource? Because God bless them, they're finding boyfriends and girlfriends and fiancés and husbands and wives while they're away, and hopefully bringing back double the doctors. So I'm just wondering if we have that ability to tap into that.
So it's a good question. I don't think I have a good answer for that right now. We know that there are thousands of Canadians training abroad, and a large number in the areas that I mentioned. So I think what we need to do is and I can tell you personally, I train residents, but I also had a couple of students who are from here in Durham who were with me last summer. They were both in first year. This is the work of the recruiter to understand exactly how to answer your question. Here's the total number of foreign trained folks. We want them back. We want to connect to them now. And I think that's part of the work that's coming this year.
Thank you. And just to add to that, I can attest to that it's not financial. In talking with these folks when they've been home to visit with my kids even.
There has to be a question here.
Yeah, so it's about how do we expose them to what we have to offer as a community, though? Like, if they're already from here and we're competing necessarily with cities around the world, how do we entice them to come back home?
We have to get organized and prepared to showcase what we have. Okay. We need to understand what's available and make sure that we are showing them every opportunity that we have everywhere here in Durham.
Okay. All right. Thank you.
Thank you. Councillor Leahy. Short, please.
Thank you, Chair. Okay, through you. So the first question is around the family health teams again. So it'd be great if there were more. There's no question that's how the doctors are trained, and they prefer that. When you're saying there's a priority, have there's been any commitments at all to enhance funding or anything at all with the family health teams, or is it just a conversation?
So I can't answer that question fully. I would tell you from my understanding of what's happening at the province that there's a commitment, but until there are dollars attached and programs running, I can only say that we need to make sure that what's being talked about is actually delivered and executed.
Okay, fair enough. Isn't there generally a problem with resources for family physicians in general, like the last 10 years, like with all the free code cuts and everything, like their pay is actually down over the last 10 years. I can personally attest, I do the books for one. And I guess the challenge is the resources need to be there. Like, are we not pushing to have the resources there from the province to support family physicians? Because that's problem number one.
Yeah, so I think that's the work of the OMA and the physicians and the Ministry of Health to sort that out. It is an important issue. It's one factor that is reducing interest in delivering comprehensive primary care. It's one issue. I think what we want to understand is how to build a high quality work life, including the financials, but a high quality work life. I don't know what this council can do in that regard, except have a good understanding of the issues and do all we need to do to support folks, both for their career and for their career choice, because I think the finances are a provincial thing, and then for their personal lives.
Yeah, no, and that's really important. And also, managing the burnout, managing the administrative overhead burden, which is. Question is, how are we tackling things like burnout and administrative burdens for physicians that are unable to handle things right now to try and keep the ones that are already trained in here in Durham?
I actually think that part of what we want to do from the point of view of educating the recruiter and the recruiting strategy is to understand both what's required to recruit, and that includes a financial component, and what's required to retain. And that's where I think there's going to be a partnership beyond this table into the economic folks and the business folks in this community, because most physicians who are trained, they spend 1 hour of 6 years learning about business, and so they come out having to join some small business knowing virtually nothing. We now need to understand that as a problem, and then what are the solutions that are beyond other doctors trying to recruit. It'll take the team.
No, I appreciate that. And then when you're saying your number one thing is saying that your statement was that it wasn't the incentives are driving it. What's the data driving that? Because 100% the reason why my wife opened a practice in Oshawa was because of the incentive that she got from the city of Oshawa and the incentive she got from the province as an underserviced area. That was 100% of the reason.
So that's data from some of our Ministry of Health friends who've been active in recruitment elsewhere, that it's a factor among many factors.
Yeah, so to me, it's a very important factor because they're coming up with so much debt. So let's focus
Counselor,
on that.
We're short on time and questions only.
Thank you. I guess my last question is, at what point would you be able to tell us what type of incentive program that you would recommend that the region and other municipalities implement to try and recruit these physicians? Like even just a timeline, because you're saying it looks like you might have a program together in June, according to the report?
I know there are a couple of municipalities who already have incentive programs that are active. The work this year will be to make sure that we talk to all municipalities and see if there's an agreement to get consensus on standardizing what that recruitment incentive looks like. Again, I want to be careful because I think the region has a particular role in making sure we get this whole recruitment plan built and off the ground, and incentives will be one component that I think will be talked about.
No, I appreciate that. And my last question is just around, so you would try and encourage all the municipalities to have like a similar incentive so they're not competing with each other? Is that where you're trying to go with that?
That's my personal view.
Okay, perfect. Thank you so much.
Councillor McDougall.
Thank you. 3 questions quickly for brevity. 1, do you find that family healthcare teams are more successful in recruiting? 2, you mentioned that by 2026 there'll be 4 million Ontarians without a doctor, or family doctor that is, and with 1,380 patients per doctor, roughly that's about 2,898 doctors that the province will need by 2026. And the third question is how do you get family doctors who have a subspecialty to continue practicing family medicine instead of just entering, say, the hospital and doing that subspecialty? That's my 3 questions. Thank you.
So first question, I don't have the data on the difference between the team, family health team recruitment success versus non-team. So and I don't know how that data could be developed. I think we could develop it internally. Second question was specifically around the shortage. Yep. So by 2026, I think for us it'll be closer to 25% of Ontarians who are struggling with primary care access. And then your third question, forgive me, was
family doctors that have a subspecialty, say anesthesia. How do you get them to continue practicing family and not just say doing anesthesia strictly and then dropping their family office?
There's a lot of work to do to make comprehensive family medicine more attractive. Folks are doing their 2 years of family medicine training, and then they're doing another year of subspecialty training, and some of them are then just choosing to do their pure subspecialty, whether it's anesthesia, hospitalist medicine, palliative care, et cetera. So I think the work is, and I'll tell you, this is a bit out of scope. I'll spend 30 seconds on this. Part of the sort of hidden curriculum in MD training is MD training used to be done a lot by primary care 30, 40 years ago. Over decades, most of that training is done in hospitals by specialists. They're wonderful people. They're exceptional people. And so what happens is you can see who the mentors are for these folks. So we're watching what's happening by accident, which is a lot of the training happens by specialists and limited by family docs. Our new program here in Durham, most of the training is done by family docs. These folks will get to see what it's like to work alongside someone who's delivering comprehensive care who really enjoys it. And so I think that's actually going to be the kind of thing that needs to happen here and everywhere to build out comprehensive family medicine.
Thank you. Councillor Shahid.
Thank you so much. Through you, Chair, I will be very, very quick. Most of my questions are answered. Fully supportive of this program. I think it's very necessary. What is one thing that you would suggest that would that other municipalities may have done is a best practice to incentivize or retention for these doctors? One thing.
Is to build a recruitment program. I know, and I'm not being silly here. I mean, when I worked with Sheila, for over a decade, it was probably 15 plus years in Clarington, and we started building a team of folks, including folks who were taking these docs with her, if they had partners or families, them too, to look at what was available at schools, at where they could work in the community, like. At housing, we were very attentive to making sure we understood what their needs were, and then making sure we met the needs. And so what happened is this team formed and built, and that's actually, I think, was helpful. It really people saw how they were being valued and saw what their opportunities were for their work and personal lives.
Thank you. I know that there is a budgetary line item in our budget as well on this, so I'm looking
questions,
forward
please.
to helping you with this program personally. Thank you.
Thank you. That exhausts the speaker list. Sorry for the rush, but we have a delegation that we have to hear before noon. So Dr. Stone, thank you, and Ms. Hall, thank you for being here today.
And thank you very much. And I know I hogged the microphone. Forgive me for that. Sheila has been fantastic. So.
Okay, thank you. We'll move on to our agenda. Ian McVeigh, Manager of Sustainability, and Sonia Wilson, Consultant, Reshape Strategies on the Curtis Transit-Oriented Community District Energy System.
Good morning, Regional Chair, members of Regional Council. I'm excited to be here today to introduce to you, or to bring back actually more information about an exciting decarbonization opportunity centered around the proposed or the planned GO station in Curtis and adjacent to the Clarington Energy Park, where of course we have the Durham York Energy Center and water pollution control plan in Clarington. I'm joined by Sonia Wilson from Reshape Infrastructure Strategies, who's joining us from Vancouver. She was online at 9 o'clock, so 6 o'clock her time. So thank you, Sonia, for being available. Sonia's worked with leading jurisdictions across North America to advance district energy planning, notably Toronto, Edmonton, Metro, Vancouver, where she is based. So they bring a lot of expertise around this that we've been lucky to benefit from. So just moving to the next slide, I'm just going to provide a bit of an introduction before handing it over to Sonia for some of the more detailed dive into the business case and model. So district energy systems, from a introductory perspective, are simply systems where you have a central energy center with heating and cooling distributed to buildings in a given area, be it a campus or a healthcare setting, hospitals and universities are common applications. But of course, in Ajax here, we have a district energy system that goes back to World War II, of course, when Ajax was home to the major munitions plant. Very common in Europe, where it's been really a key strategy in many northern European cities for reducing carbon, but also from an energy security perspective in terms of them able to respond to the energy crisis that was caused by Russia's invasion of Ukraine. It's a very powerful decarbonization opportunity that's receiving new interest in North America and beyond, but is also very site-specific in terms of energy options and technical and economic feasibility, which is why we did this detailed study that we're going to share with you. So on the next slide, and this is in the report on this agenda, you'll see that district energy is really supported by some key regional strategic planning documents, namely our draft regional official plan, Envision Durham, which speaks directly to the importance of district energy systems to provide energy in new community areas, particularly greenfield areas where we're planning for higher density. The Durham Community Energy Plan also speaks to district energy as one of the top 3 or 4 opportunities that actually represents upwards of 15+% of the total emission reductions we're hoping to achieve over the coming decades. So it rivals sort of electric vehicles and building energy retrofits as some of the key strategies. And of course, going all the way back to 2010, when the region negotiated the community host agreement with Clarington around the energy from waste facility, that host agreement really does speak to commitments to look at opportunities to utilize the heat from that facility in a district energy context. That's where I'm going to stop in terms of introduction and then hand it over to Sonia to walk us through some of the key points on the business case. I assume you're there, Sonia.
Just want to make sure everyone can hear me.
There you are.
Okay, great. It looks like my video might be frozen, so let me know if I should go off video so you can hear me better. So this work Ian mentioned is building on prior work that was done looking at district energy potential across the region of Durham. The prior work was completed in 2022, and we moved immediately into this more focused study on a district energy system business case for the Curtis transit-oriented community area, really focused on that high-density development around the GO station. Next slide, please. So the feasibility study looked at 4 different district energy concepts. We looked at 2 that provided heating only, and we looked at 2 that provided both heating and cooling services to connected buildings. And we also looked at 2 different low carbon energy sources for each of those systems. One would be heat recovery from the Durham York Energy Center that Ian mentioned, the energy from waste facility, and one looked at heat recovery from treated effluent at the Curtis Water Pollution Control Plant. Next slide, please. So we did a life cycle cost and GHG emissions analysis on these 4 different options. And based on the outcomes of that analysis, the heating only district energy system with heat recovery from the Durham York Energy Center was selected as the preferred concept for developing the business case for the Curtis district energy system. The reason being that it performed best in terms of both capital costs, life cycle costs, and GHG emissions reductions. And so this is the one that we chose to move forward with to develop a more detailed business case. Next slide, please. So just to compare what would be an on-site alternative or a non-district energy alternative to the low carbon district energy system, we looked at a reference case that would be 100% electrified building heating, but at the building level, so each building has its own air source heat pumps, electric boilers, et cetera, to provide low carbon heat at the building. So we compared that to the district energy system that provides a comparable level of GHG emissions reductions. This comparison shows that the district energy system provides a comparable level of emissions reductions at a lower life cycle cost than the on-site electrified alternative. An important observation here is that the on-site electrified heating alternative, about 40% of those costs are, on the life cycle basis, are electricity costs or fuel costs. And so that represents a major risk for ratepayers, energy users, simply because there's a lot of uncertainty around the cost of electricity in the future. And we're looking at a 25 or a 30-year, life cycle analysis period for this project. Next slide, please. So there is a lot of detail on the slide. I think everybody got the council report with the executive summary in a bit more detail. But really what we want to emphasize about this business case is we set up the base case so that the district energy utility has full cost recovery. All costs, capital, operating, financing, everything, all those costs are recovered through a combination of connection fees and utility ratepayer rates. So it's set up, the business case is set up to be financially sustainable from the start. The ratepayers, the rates that we put in as a preliminary indicator of what rates would look like for connected buildings in the community, they're benchmarked to be less than what ratepayers would pay for an on-site electrified heating system, so lower cost for the same greenhouse gas outcomes. And similarly, the connection fees that landowners would pay to connect to the system are calibrated so that they are less than what the landowners would pay to connect, or sorry, what they would pay to build an on-site electrified heating system. And the idea is that those connection fees would sort of scale in response to any green development standards that might be implemented in the future. But the goal is to kind of have that benchmarked against the landowner's avoided cost of what they would otherwise have to build to provide heating for their building. Next slide, please. I mentioned this a little bit earlier, just to illustrate my point a little further. The exposure to escalating electricity costs is greatly reduced for ratepayers in the district energy model versus the electrified heating model. You can see on the right graph here that if we see higher than anticipated or higher than modeled, I should say, electricity rate escalation, that ratepayer energy user costs go up much more steeply in the building electrified heating system, scenario versus the district energy scenario. That's because most of the heating from, or all of the heating from the district energy system is coming from non-electric sources. There is a small or a greatly reduced or dampened relationship between the cost of electricity and the cost of heat in the district energy scenario versus the electrified heating scenario. Next slide, please. So in the business case, we did do an extensive feasibility or extensive sensitivity analysis on the base business case and what factors would impact its variation from either being generating positive revenue, positive income for the otherwise fully revenue neutral utility versus where would there be a revenue shortfall. The findings of this really show like the higher than expected capital costs would negatively impact the business case. Another key finding is that connecting the Curtis Water Pollution Control Plant as a load on the district energy system is an important load. So having that there is important to the business case. On the upside, the sensitivity analysis shows that seeing faster growth or higher density growth in the Curtis transit-oriented community will greatly improve the business case. So faster build out, higher density really provides a lot of benefit to the district energy business case. And lastly, we assumed a cost of capital benchmarked at the Infrastructure Ontario rate. However, if the project were able to access low-cost financing, that greatly improves the project business case as well. And I can go to the next slide now, please. So on the topic of low-cost financing, there is a lot of money out there for great low-carbon district energy projects at the moment. The Canada Infrastructure Bank has signed deals with Markham District Energy and Wave Energy Corporation. So those are large amounts of low-cost financing that could get a district energy system off the ground under the right circumstances. And there's also a lot of smaller amounts in terms of grant funding that can support the development of these projects. Next slide, please. So you may be wondering who's going to own this district energy system if in fact it gets built. That is an open question right now. One of the tasks that we're going to be working on in the coming months is evaluating different ownership models for the utility. Across Canada, there is a wide range of district energy ownership models, from fully public to fully private, and a lot of great innovative hybrid models as well. So we'll be working with the region to evaluate these options and help determine a preferred ownership model for the utility. Under any of these ownership models, the municipalities are going to have a really important role in managing the connection risk and ensuring that buildings do connect to the system, because that is really vital to the district energy business case, as I pointed out earlier. So next slide, please. So with that said, one of the near-term goals is to ensure that the secondary plan for the Curtis Transit-oriented community does have supportive policies and supportive language for district energy to enable this project to move forward in the future. Next slide, please. And this is my last slide. So in terms of timeline, really near-term priorities are making sure that the secondary plan supports this district energy proposal, and completing that evaluation and determination of a preferred ownership model. The goal is to have the district energy system up and running in time to service the first buildings that are going to be developing in the Curtis Transit-oriented community. So to make sure that every single building that should be connected to this district energy system is able to connect. So that will mean that in the near term, the next 2 years, we'll also be or the region will also be working on negotiating the necessary agreements to deliver this first phase of the project. Once that project is up and running, and that will be with a temporary boiler plant just to manage timelines and investment risk, the region intends to work on negotiating the agreements and design and everything that's necessary to make that connection to the south to the Durham York Energy Center and access that low carbon heat that's being produced at the Durham York Energy Center today. And then in the long term, the vision is that the system could expand beyond the borders of the transit-oriented community and serve nearby development, and potentially in the long term even interconnect with other district energy systems to have a region-wide decarbonized district energy system, which is kind of the vision that's presented in that 2022 report by FEV Energy. So with that, I will wrap up and hand it back to Ian.
Thank you. There are some, one last slide, sorry.
A quick we're seeking here. We are looking for endorsement in principle of the concept that's put forward in the report, and that's mainly because I'm sure, as you can appreciate, there's a lot of stakeholder engagement that needs to happen around this concept, and so having an indication of council endorsement in principle will help us in our engagement with Clarington around the secondary plan, engagement with funding and financing agencies to explore grant and low-cost financing opportunities, and finally in working with the landowner group and utilities around evaluation of ownership and governance models. So that's where we're at. Thank you.
Okay, thank you, Ian. First, with questions, Councillor Kerr.
Thank you, Chair. Just one question. In the slide, the penultimate slide that you presented today, it had the timeline of implementation. I just was in wonderment at why it would take 16 years to make the connections 2034 to 2050. And I'm just wondering, that's an awfully long time. And why would it take that long to make those kind of connections?
Through you, Chair, to Councillor Kerr, this is really based on the development timeline within the Courtice Transit-Oriented Community. It's right now at the secondary planning process is looking at a actually 30 to 40 year build out within the area. And so that's really the district energy infrastructure investment is going to need to be timed and phased to align with development so that we're not sinking too much capital in the district energy system before there's buildings to take the heat.
Well, I guess we have to get the go out there first, don't we? Okay,
Yes,
thank you, Mr. Chair.
Thank you, Councillor Wu.
Yeah, through the chair, and thank you, Ian, for the presentation. And once this goes to council to be endorsed as you're looking for, you will be coming to Clarington to bring this presentation to our council, will you?
Yes, through the regional chair to Councillor Wu, we are working with Clarington staff to see about getting onto an upcoming council agenda at your table at the Clarington Council.
Okay. I hope this will move forward. It's great. And when we're talking about the low carbon future and I'm looking, and I have to look in the summary, 130,000 tons of cumulative avoided greenhouse gas emissions. Presenting that and what the federal government has in place, should it be very hard to get any financing?
Through the chair to you, Councillor Wu, we've seen a lot of evidence of federal government through the Canada Infrastructure Bank and through the Green Municipal Fund of the FCM, strong interest in supporting district energy systems, as we had presented here, more than $1 billion in financing, I think just through the CIB alone in the past several years. So strong indications, because there's a business case here. So not just government sort of subsidy grant funding, but also financing from that return on investment side of things. So there's a lot of interest, I think, from government, but also potential institutional investors and other sources of capital.
And the landowners group.
And potentially the landowners group.
Okay, thank you.
Thank you. Mayor Schumer.
Thank you, Mr. Chair. Through you, just a quick question. So I just wanted to clarify, because sometimes people's understandings of endorsing things in principle can be different. But just to confirm where we stand by endorsing in principle as far as commitments on this.
Sure. Through the chair to you, Councillor Schumer. I mean, I think what we're looking for is endorsement or principle of the concept as presented, but also recognizing that there's additional due diligence that will need to happen as outlined in the report, identifying a governance and ownership model, identifying financing, grant opportunities, working with utility partners, et cetera. And so the plan is fully to come back to council with an updated business case later in 2024 once we've done some of that due diligence to present an update and refinement of the business case and project plan as we have it at that point.
So it anticipated that this year we will be kind of making, say, the final decision on moving forward with this.
Yeah, through the regional councillor to you, there are impending timelines associated with the Curtis Transit Oriented Community secondary plan, and as well utility servicing plans. And so it's really critical that we advance this to a point of go, no go, as early as possible to enable us to align with infrastructure and development planning that's currently happening in that area. And so that does mean that we are working towards bringing an update back to council this year.
Okay, thank you.
You're welcome.
Okay, thank you. That exhausts the list of questions, so thank you for your presentation. Mr. Clerk, lunch is in the back room. Members of council, there are a number of reports that will need to be dealt with. I think what I would ask of you is somebody would give me a motion to break for, somebody's hungry, to break for 20 minutes, allow you to grab your sandwiches or grab your lunch, whatever it is, and come back into the room. Moved by Councillor Miriam Pietri, seconded by Councillor Shahid, on a 20-minute recess. All those in favor? In opposition? Seeing none, Mr. Clerk, we're in recess till 12:10. Call the meeting back to order. Okay, we'll call the meeting back to order. Mr. Clerk, could you do a roll call, please?
Thank you, Mr. Chair. Electronic roll call is starting now.
Okay, thank you, Mr. Clerk. We have quorum. Okay, the clerk will note that. Members of council, we're on to reports. We have a number of them. We will do them one at a time. We'll start with report 7.1, Curtis Transit Community District Energy business case update. Okay, just move the recommendation. Okay, I'm looking for a seconder. Seconded by Councillor Wu. The item is now on the floor. Members of council looking at the speakers list. Seeing none, I will call the vote on the item. All those in favor? In opposition? Seeing none, that carries. Next report is on page 67 of your agenda. It's the Durham Region response to provincial consultation on proposed changes to the Ontario Regulation 1316/07. There is a recommendation here. Could I get a mover? Moved by Councillor Gerard, seconded by Councillor Kerr. The item is now on the floor. Questions to the item, Councillor Kerr.
If you'll indulge me, just a very short congratulations to staff on this. I think good news is always terrific. And all of their concerns and future implications were stated clearly. The one thing I wanted to comment on, I'm the council rep on the active transportation, and I was really glad to see all the possibilities and enhancements and advantages of this park and how it can link to the AT. Clearly spelled out. I think staff did an absolutely terrific job, and I thought I'd just like to give a little pat on the back today.
Okay. Mayor Barton, online?
Yep. Can you hear me?
We can hear you. Go ahead, please.
Yeah, I just want to say I support this 100%. This is a great project for Uxbridge, and Councillor Kerr, thanks for your support on this as well. Thank you.
Okay. Anyone else wishing to speak? Seeing none on the item, I will call the vote. All those in favor? In opposition? Seeing none, that carries. We'll move on to item 7.3, Family Physician Recruitment Program. You'll find it on page 76 of your agenda. I need a mover, Councillor Anderson, seconded by Councillor Chapman. The item is on the floor. Mayor Schumer?
Thank you, Mr. Chair. Following up on the presentation, I have quite a few questions regarding the proposed, well, I guess the proposed setup of this. Firstly, the cost sharing, has that model kind of been worked out on how that would be developed for the region and the municipalities?
I'll go to our Commissioner of Economic Development and Planning, Mr. Bridgman, but I believe it has.
Thank you, Mr. Chair. It has, and the report speaks to that a little bit to date. And if I may, for the benefit of committee, the person in the region that's been closest to this is Simon Gill, the Director of Economic Development. He's online. He might be able to speak to it more if you would like.
Okay, Mr. Gill?
Yes, good afternoon, committee. Through you, Chair. The cost-sharing formula is yet to be developed. The initial scope of work that was performed in collaboration with the area municipalities, the cost was roughly shared about half by the region, half by the area municipalities, and again, roughly proportional to population. But for this program that's on the floor for consideration, the details are yet to be worked out.
Okay, thank you very much. Now, this speaks essentially to a 10-year program. I'm just wondering. I mean, there's quite a few costs in there. Obviously, we'd be committing municipalities and the region and future councils to this program. Is that correct? That once this is signed off on, it is a 10-year program and commitment for everybody?
I'll go to the Commissioner of Finance.
So through the chair, recommendation C is where we have some provisos in there. So that's where it's subject to annual financial participation, to your earlier question, but it's also further subject to an annual update to council and some metrics, performance metrics. So it will come to council on a consistent basis for them to be sure that they're getting the value for their investment.
Okay, I asked that partially because obviously there's a position being created here with obviously everything that goes along with that, and so if it's annually reviewed, that individual, I guess, could be terminated. Am I correct in assuming this, that if it's going to be reviewed annually, that position could find itself gone in 1 or 2 years?
So through the chair, and perhaps Simon may wish to add to this, but we did reference in 3-year increments so that there was long enough, because a performance metric after 1 year, like these are long tail, and as Dr. Stone spoke to and Sheila Hall, the first cohort of the 20, for example, it's going to be 6 years. So it will take a long tail. What we're cognizant of is that council will want to see what's occurring with it. So what we built in here is 3-year increments in order to try to establish that rotating time frame. And I say I'm not sure if Director Gill wants to comment any further on that.
Yes, through the chair. I think the commissioner covered it quite well. I'll just add that the 3-year increments with a view to this being a longer term program is really based on the nature of the opportunity in front of the region, which is that there are learners in medical school for 4 years and then in training for 2. So in 6 years, we'll see the greatest fruits from our investment over the course of the next 6 years.
Okay. And with respect to the metrics that I guess are being developed on this, will there also be milestones where, you know, we're anticipating something to be achieved at certain time periods?
Yes, through the chair. In the report, it speaks to KPIs that we envision measuring this program against, paragraph 5.6. In the initial year, next year, it would be the setup of the program and the establishment of regular reporting deliverables. And then on an ongoing basis, we would track outreach, retention of learners, retention of existing physicians, satisfaction with that recruitment process, and then eventually we would actually track new family doctors, and we would try and track that by municipality.
Okay, I know I've run out of time, but I guess I'm going to have to come back for a second round on this. Thank you.
Thank you. Councilor Marin Pietri has stepped out. We'll go to, unless he's online. I don't see him. We'll come back to him. We'll go to Mayor Watton.
Thank you, Mr. Chair. And through you, I just have one question, and it's under the 5.3 point, and it speaks to recommending that area municipalities do not offer financial incentives and so on and so forth. And I'm speaking from strictly a Scugog-centric perspective, because traditionally over the years we have done that, and it's not so much choosing to, I would like you to explain to me exactly what you mean by recommending that a municipality doesn't really do their own thing, or is it strictly a financial incentive direct to a doctor? I mean, there's lots of other ways to create incentives as well. So if you could just qualify, this is the second time in 2 weeks that I've seen something where the region is recommending that area municipalities don't do something. So if you could qualify what you mean by that, I would appreciate it. Thank you.
Certainly, through the chair. That paragraph was with respect specifically to inducements to attract a family doctor to come to Durham Region. And if you look at the appendix of Ms. Hall's report and the team's report, you'll see a variety of other municipalities do offer inducements. About a dozen in Ontario offer, on average, about $100,000 in exchange for a 5-year commitment. What we're proposing here is that the recruitment program itself, we hope, combined with the fact that we have the Queen's program, will yield good results on its own. It's certainly in the purview and up to each area municipality whether they would like to offer their own financial inducements, but the reason we included that paragraph is because it may create that internal competition, and then it would be a race among area municipalities. We know we're competing with other areas around the province, but that was the purpose of that report. Of course, it is certainly up to each area municipality whether they would like to offer their own financial inducements for recruitment.
Thank you. As I said, I was just curious if it was referring specifically to the inducements to particular physicians, or, I mean, there's lots, as I said, there's lots of other ways to offer ways to help advance the recruitment. So thank you for qualifying, and I think it's a fabulous idea, and don't get me wrong, fully support this moving forward. So thank you.
Thank you. Councillor John Neal.
Yeah, thanks, Mr. Chair. I was just wondering on the report 3.8, it's not mentioning Pickering as being with any financial commitment.
Through the chair, the initial scope of work to provide services over the course of the first 18 months, it was a voluntary request to the area municipalities to financially contribute, and those that volunteered were listed in the report.
So Pickering's coming forward later, or what's as a signatory, or what's the deal with that?
Through the chair, if this report is passed by council, then certainly we would look to include Pickering in the discussions around a reasonable cost sharing for the recruitment program.
Yeah, okay, thank you.
Mayor Roy?
Thank you very much, Mr. Chair. And just around the incentive program, in the past, when and it's referenced, I know within the report where the topic of the recruitment has taken place, I know that back in like 2006, and I believe even Oshawa had the incentive program at that point in time. Shocking, and and I remember being a part of the whole recruitment, and it was about the incentive. But I also know that even within Whitby at that time, and Byron Street Medical Practice is one of the examples. We brought back from Ireland doctors that were not from our municipality, but we brought them into the municipality to practice here. And I actually have one of them as my doctor. The other one just has retired, but it's like taking a look at some of that past practice. I know, for instance, in Whitby, the staff that are within the town of Whitby were not present when we did the recruitment, so it's new experience for them. But I do know that there has been past practices that where we were successful, even though we say that this is a national matter, there is an ability to have that local component because for medical schools, for a majority of our own graduates in Ontario who come out of the high school program, to be able to get into medical school program, they need to go overseas in order to come back because in our own medical programs, we're not taking our own. Has there been any, and I actually, Simon, I will flip you an email from a local Whitby resident who actually is part of the students who do go overseas, and she has reached out to me. But I don't know, even within, with Dr. Tony Stone, that to have the understanding as to how can we bring people back to our communities. It's a big one because there's a lot of students who have left our community.
Yes, through the chair. I think that is a huge opportunity, is the international, repatriation of graduates from other jurisdictions. And I think that the recruiter, if this program were to be established, the recruiter would be a very excellent point person in creating the appropriate outreach program, marketing program, perhaps even visiting, graduate career fairs in market might even be an option, or organizing tours of Durham region for those graduates abroad. All activities that could very well be part of this recruitment program. And then speaking again on the incentive side, yes, certainly I think incentives are working elsewhere in Ontario, and I think they have had a history of being a part of a successful strategy in various respects in the past in Durham. And so it could very well be part of the solution. The reason why they're not being recommended right away is, I think, yet more work to be done. And of course, the dollars will add up very quickly if we start offering these incentives.
Okay, I appreciate that. And just second through you, Mr. Chair, and it's what Dr. Tony Stone spoke about. It's the story of what our community can give. And I was in attendance last year to a roundtable discussion over at Deer Creek with a number of our local physicians and family teams. And I was at the table and they were asking me about what sports are offered, how are our schools. These are things that we need to be paying attention to as well, and how can we tell that story very well to the recruits and to their families, because it's about their whole family situation as well.
All right, thank you. Councilor Mayor Pietri.
Thank you, Mr. Chair. I'm not sure if we touched on this, but and the report is very good, and I believe that staff are doing what they can to be able to coordinate this with physicians themselves. The presentation made today was one that I think that many municipalities across the country would probably receive in the next number of years. I know that in the city of Oshawa, and that's what I want to ask through you to staff, whether they considered the physician recruitment task force policies that we put together in the early 2000s in the city of Oshawa, because I know that Councillor Leahy touched on it. A lot of this is lifestyle and the way that we're building our community, but and the other half of the equation, and I know it's very difficult to simply allocate, you know, that part of the equation, you know, to a public discourse, but you know, the bottom line is the bottom line. I think money comes down to there is a deciding factor when it comes to money, and I know in Oshawa we offered incentives, and there was a greater financial contribution, very successful through the Chamber of Commerce in the city of Oshawa. But we heard today that we're going to be competing with other communities, and then it's just a race between us and other communities as to, you know, what kind of monies are offered up. So my question is more specific toward how we're dealing with provincial and federal levels of government and their ability to further remunerate doctors so that they may find coming home from places like Ireland or the United States as a preference for them, because we're working in the best that we can to ensure that lifestyle is optimal. But the bottom line is that they may be paid less in Canada, and I think that we need to have that conversation with other levels of government. That's my question. So when we look at the report and we try to figure a way to attract new doctors, is part of that conversation with the other levels of government who actually remunerate them?
Oh, Simon, go ahead, please.
Sure. I was going to take a first quick crack at that by saying that, yes, I think the report from the physician engagement team is clear that the province plays the primary role in workforce supply. And of course, that comes down to workforce planning, training, and salary. But perhaps your question as it relates to our work and addressing that overall workforce supply, maybe Doctors Kyle or McTavish might have a better ability to answer that part of your question than I would.
I appreciate the answer that was already provided, but if there's anything further, I'd be happy to hear it.
Dr. Kyle is on.
Yeah.
Dr. Kyle? No, sorry.
Mr. Chair, I'll cede the floor because I think that this is a bigger conversation. I want to thank staff and you and the region for engaging in something that we did very well in Oshawa, and I do know that we're going to have to pay to play in this case, because I think federal and provincial levels of government aren't doing that, and if it sets us apart from others and creates a blueprint for other areas in the GTA or the country to benefit from, that's something that we can't really control, but we do have a need here, and I think we need to press forward with trying to find the best way possible to attract doctors to Durham Region.
Thank you. Councillor Wu? Oh, sorry. Push your button again, please.
Okay, thanks, Chair Henry. Just within the report, and certainly it's very, to me, it stands out, a very compelling shortage of 145 family physicians affect 180,000 Durham residents. And when we're looking at the physician in the report, it speaks about maybe about 1,400 patients that each physician would have, 1,380. And 100 in Durham, family physicians over 60. Now, I did make the comment, not saying that, yes, they're of that age, but nobody's saying that they have to retire. But could I ask, these figures, how accurate are they? When were they compiled?
Simon? Mr. Gill?
Yeah, through the chair, I believe all available research on the matter was used by Sheila Hall, Dr. Stone, and the rest of the team preparing the report. There was a member of the Ontario Health team that was a member of the author group of this report, so they were relying also on provincial data, and it was all quite recent as far as I'm aware.
Okay. Because we are a growing region, we talk about one of the fastest growing, so as we grow, we're probably slipping behind in the number of doctors that we have to our residents. Now, I want to give, and if you allow me some latitude, because I fall within that scope of my family physician gave up her practice. But I was lucky that there was another physician taking over her patient file or patient list. But again, this is a couple of years ago, and I, in my own mind, I'm a picture of health. I'm invincible. I don't go see the doctor. I am not a drain on the healthcare system. But lo and behold, the doctor's nurse phoned and said the doctor would like to meet me. And, I go in and she has my history up on the screen. Checked my heart, my blood pressure. Again, I am not Superman. But I have a blood test, requisition of blood test. I go in for the blood test. My PSA is elevated over my 2019 level. So you have to remember, over the pandemic, nobody is going to see a doctor, let alone a blood test. Second blood test confirmed that. Sent to, a specialist, a urologist, digital rectal exam, biopsy. Yes, I did have prostate cancer. So that was, I had my operation 7 weeks post-op, post-surgery, this past Monday. And here I am. But if I did not have a physician, I would have just sailed right along, because when they did a test on that prostate and my lymph nodes, it had not gone out of the prostate capsule. But if I would have left it, it would have metastasized or spread, and then more complications. And there was something that's in the report. Extensive evidence demonstrates that access to primary care physicians improve health outcomes and reduce overall health care costs. If I would have sailed on, and I don't know when, would it be blood in the stool or blood in the urine that would trigger something, say, look, you better go see a doctor. But I think this is vitally important that we support this. Now, I know each municipality, Durham region is very large. And I'd be interested in, if I could ask this question, for the healthcare recruiter, one thing is to recruit physicians. Another one is to retain. And what is the role of this recruiter? Recruitment and retention. And again, if we can recruit, is it up to each municipality to say, oh, come to Clarington or go to Uxbridge or Brock or Scugog or wherever? Unless we get in as municipalities with incentives, how is this going to play out, or is this a work in progress?
Mr. Gill?
Through the chair, on the delineation of the scope of the recruiter between attraction and retention, certainly retaining the Queen's University program medical trainees to remain living in Durham and land here and start their family practice will be a primary focus. How far it extends into the retaining of existing or currently practicing family doctors is yet to be determined. And then how will each area municipality contribute? The program is envisioned to have a regional scope, so it would certainly look to take into consideration all the different factors at play across the region, urban versus rural, and try and attract doctors to all areas of the region, all areas of need. As has been discussed earlier, whether each area municipalities feels the need to offer their own incentive to increase their ability to be attractive, certainly that would be up to the area municipality. Or of course, regional council could consider, a regional approach to that as well, but all to be determined.
Okay, thank you. And just by one last point, and I did make a comment about 10 years ago in the municipality of Clarington, we did have an incentive program, a limited amount of money, obviously. I think if I could recall back that we were able to attract 5 physicians, but within that, and you can see from Dr. Tony Stone, that group that they have there is a very, very tight-knit, and we had at one time, it was just a gathering of all the physicians, just to get to know each other. It was just like almost like a wine and cheese. And I think I will bring that back to the municipality of Clarington, at least to show thanks to our physicians, the work that they do.
At a time.
Thank you. But again, they do a great job. Thank you.
Councillor Brenner.
Thank you, Mr. Chair. Through you, I just want to go back a bit to 3.8 a moment. I am very disappointed that the City of Pickering did not participate. And I'm wondering through you, Mr. Chair, to Mr. Gill, can you clarify where that discussion took place initially? Was it at a staff level or with economic development? I'd like to learn more about where that discussion took place.
Through the chair, Dr. Tony Stone approached, I believe it was our regional chair and CAO, about an urgent need, which was the shortage of family doctors. We organized a call, invited at the staff level, the senior leadership from each area municipality in the region to hear this request from Dr. Stone, and it grew from that. And the discussion largely was at the staff level around how to fund a very rapid response to this request, because the new cohort was coming very quickly. They were going to be starting in September, and this work was in the summer. So, yeah, the discussion around the initial cost sharing formula was at the staff level, and as I mentioned earlier, we are more than looking forward to having that discussion on this new scope of work and how the cost sharing formula could work with the City of Pickering.
Thank you so much. I mean, obviously can't put the clock backwards, but certainly we'll be supporting it today and pushing to get Pickering's commitment.
Thank you. Second time around, Mayor Schumer.
Thank you, Mr. Chair, and again through you. The strategies that are outlined on pages 21 and 22 that are implemented by various municipalities, do we have stats on how successful those have been over the many years? And I know you probably don't have them with you, but if those stats do exist, can they be forwarded to members of council?
Through the chair, I don't have those stats at my fingertips, but certainly we can report back if those are available. I'll request them through the Durham Physician Engagement Team that drafted the report.
Okay, thank you. And with respect to the budget that's outlined on page 29, it indicates, of course, that the recruitment person at the region will be paid $120,000. Is that including all benefits? I'm just wondering. I mean, the actual salary would then be significantly lower, would it not?
Through the chair, I'll quickly clarify that it's proposed by this report that the physician recruiter be housed within the DOHT, which is actually not within the regional corporation. This is a separate entity, the Durham Ontario Health Team. That's where it's proposed to be, and yeah, my understanding of the budget is that it would be $120,000 inclusive of any salary burdens.
Okay. And the stipend that's outlined there, is that part of an incentive kind of budgeting process, or is that something else that gets paid out each year to a doctor?
Through the chair, my understanding of that line item is that there would need to be a family physician that was primarily involved in this program as an advisor, helping to guide the ongoing work of the team, a regular work planning, and that's what that stipend is for one family physician that is actively involved in the recruitment program.
Okay. And how will this all play out with respect to other organizations in the region that obviously do doctor recruitment? And I think, of course, of the medical associates in Port Perry. I think of the Community Health Center in Brock. How will this shake out with them? Because they could come up with their own incentive programs where we're trying to entice the local municipalities not to do that, to get into competition with one another. So how is that all going to play out when you have these other organizations that are arm's length from the region and local governments? How are you going to manage that?
Yeah, through you, Chair. I'm afraid I don't have an answer to that. I think as this program gets designed more fully, the collaborative approach with all the key players across the region will have to be scoped out.
Okay, thank you. I've got some real concerns about some questions on this program and how it's going to play out, and whether or not certain hands are going to be tied or not. But I want to thank you for the information contained in the report.
Okay, thank you. Councillor Anderson.
Oh, sorry, belaboring the point. I'm just going to ask for a recorded vote. So I want you. Thank you.
Record a vote at the appropriate time. Councillor Neal.
Yeah, thanks, Mr. Chair. And I'm glad to see that Pickering is going to look into this, because I was surprised to see that they weren't in the report 3.8. So I think that helps me out. But in 2004, when I made the resolution in Oshawa to start a doctor's recruitment, we were short 40. And I can tell you it was a huge success. And there was some skepticism there whether we should be involved in that or not. But all the residents in North Oshawa, no physician, and I heard that they were going up to Toronto, and quality of life it's a huge part of the quality of life of the new residents. But having said that, we ended up around 2008, I think it was, there were 14 doctors looking for patients. So, I mean, it was a huge success, and everyone was on board in the end. So I'm glad a recorded vote was asked for. Thank you.
Thank you. Mayor Carter.
Thank you very much, Mr. Chair. I want to just say this, that I think that there is no fast way out of this, but we are lucky enough and fortunate enough that this program exists at Lakeridge. That's first of all. Second of all, I think that there's been a lot of work that's been put into this strategically, and I feel confident, and I can speak for the city of Oshawa, that we will be participating at whatever level is necessary in regards to making sure this program is successful. I think that we have a unique opportunity to be able to actually address the family doc situations. I'm pleased to be able to say that developers have even shown interest in regards to what role they can play, Mr. Chair, in regards to getting physicians ready as they graduate to make sure that their family practice can open the next day. And I think these innovative ideas and the leadership that is being demonstrated at the region of Durham, based upon what Lakeridge has to offer and this unique opportunity, should have everyone's support. So I'm hoping that there is a recorded vote that is being called. If not, I would request one. But I support this program 100%, sir.
Thank you. That exhausts the speaker list. Mr. Gill, quick question, and I expect you probably not to answer this one. But if the government of Canada continues to increase the challenges we have with asylum seekers and refugees, and the challenges we have with expected to double the capacity of the population in Durham region and throughout the GTHA, wouldn't there be some sense in doubling the size of the number of students that could go to medical schools in Canada so our students wouldn't have to go outside of the country? Simon, you don't have to answer that. But I will give you a question, Simon. I would be curious if anyone has ever done any research on why young, talented people choose to leave this country to go to medical school in another country.
Yeah, Chair, I actually don't know. That's a good question. I'd be happy to do some research on that point.
It would be interesting. I know that other countries, in particular, New Zealand at one time did a repatriation of people that were had specific skill sets around the world and was very successful. But I don't really expect an answer from that. But in logic says if you double your population, you need to double all the assets within a municipality to meet the needs of the people within your communities. There was a recorded vote called on this item. Sorry about that. That was my rant for the day. We'll call that vote now.
Thank you, Mr. Chair. Recorded vote is starting now. Looking for Councillor Leahy remote. Second call for Councillor Leahy connected remotely.
If Councillor Leahy is having difficulty and you can see him online, ask him to email his vote, please. Okay, that carries by all members present. Members of council will move on to the 7.4 approval of the memorandum of understanding between Durham Region and the partner conservation authorities. It's located on page 118 of your agenda, moved by Councillor Chapman, seconded by Mayor Roy. The item is now on the floor. Mayor Schumer.
Thank you, Mr. Chair. Just a quick question to staff. The increases that are proposed in the report, what do they represent as far as an actual percentage increase? I think it was mentioned it's nominal, but just wanted to check.
So through the chair, it's very minimal because in one, we have to do a bit of an increase based on switching the funding methodology, and the other one, there's a bit of a decrease. So it does not have a significant bearing on our budget discussions, and we have factored this into where we're sitting right now in working through that process.
Okay, thank you very much.
Thank you. Seeing no one else on the item, we'll call the vote. All those in favor? In opposition? Seeing none. Next report is report number 7.5, Community Mental Health Crisis Response Service for Durham Region. It's located on page 161 of your agenda. Can I get a mover and seconder? Moved by Councillor Anderson, seconded by Councillor Shaheed. The item is now on the floor. First is Mayor Carter.
Mr. Chair, I'm wondering, would it be appropriate to ask questions through you to our guests that are in the gallery?
Are you talking to DRPS?
Those fine people in the black.
Over there? If they're able to answer the question, and of course staff are here to support you as well.
That would be great. I'd like to ask in regards to their interpretation of this report and some of their concerns with this report, if that's appropriate.
If you're not able to answer the question, then we'll have to get back to you. But
I'd appreciate it. I'd like to also direct the same type of question to our EMS folk, if you don't mind, please, sir.
Okay.
Thank you.
Thank you.
Thank you, Mr. Bovey.
Thank you. Thank you, Chair. Thank you, Mayor. I do like to surround myself with very smart people. I've learned that. So I do. They're all good. So if there's anything more specific, and I'll count everybody here. Inspector Gordon Oblinas, obviously, who manages 911 comms, and Staff Sergeant Amanda Hoover, who oversees sort of our community safety and our mental health programs, including the mobile unit and crisis call diversion. So she can, obviously, if you have more specific questions. Thank you very much for us being here today. I wanted to just say, and obviously people know that before I came to police, I worked in mental health for 12 years. And I just wanted to preface, I believe everybody here, whether it's staff, council, and even Rachel, the consultant, at the end of the day, we share the same vision of better outcomes for people in mental health distress, mental illness, and addictions. I honestly believe that's the case. In reviewing the report, like yourselves, we had a number of questions that I think still need to be further explored and understood, especially when we're talking about delivering some of those and expectations that council would like to see. And I think that just needs further exploration. I think couple of the issues, obviously, adding sort of a fourth tier or 911 presents a whole host of questions around cost, training, impact on services, risk, a lot of things that we need to further explore. The second one, just high level, like when we talk about outcomes, and I watched the presentation today and it talked about high quality instant access and high quality access to care. And I think those are some of the concerns that we have is we're making promises for better outcomes when we don't really know, because we know that the system itself has challenges, wait times, access to care, quality care, evidence-based care. There's a lot of issues that really are going to be the bottom line of impact. And if we can have better outcomes, for our citizens, that obviously will help policing, right, as well. So if we're actually delivering the things that we promise, and some of the data that we had compared to what we presented today, we're not necessarily seeing it. We talked a little bit about crisis call diversion that's in place right now, and this notion of if we have another tiered response, we'll see less impact on police. Well, early data we have is showing that some of the same people already connected to services are continually accessing 911 and police. And we need to further explore why that is, if they're already connected to multiple services. So just saying that we're going to have another tiered response will have an impact on police, and that we haven't seen the data. And I think clearly our role, and I'll leave it at that, is to really, we need to drill down a lot of questions you had today for the consultant we still have as well.
Mr. Chair, I know my time is running short, so I'm wondering if I could direct the same question to a representative from EMS.
Well, the chief is here. Okay.
Chief has shown great leadership by passing the baton.
Through you, Mr. Chair, the program itself, everyone agrees that we need harm reduction, right? I think the thing that's salient here is we're very different than Toronto, right? We have different legislation. Our dispatch centers for paramedics, it functions differently than Toronto's does. So just because it's working in Toronto doesn't mean that it's going to work here. I would suggest that $10 million is a lot of money to build an in-house, a Durham-made solution for this. Ultimately, at the end of the day, it's about getting people the care that they need at the right time. So I think that being our starting point, we can work forward, whether it be with this report and this model, or if it's a different model of our choosing.
Well, Mr. Chair, I do realize I've got 5 seconds left. I'm just wondering, to the question of both EMS and DRP, would it be beneficial if, as this process rolls out, that we did hear from Toronto on what they're experiencing, what their challenges were? So it's not secondhand information, we're hearing directly what they're experiencing, and maybe we might even have a representative from Toronto Police that could make themselves available so that we could understand what they're experiencing. I'm just wondering if
we could try and facilitate that. Obviously, they have a different system with the Gerstein system, the 211, than that's being proposed here. But certainly, we could reach out to our counterparts to provide you with that input.
I would find it very valuable to not only hear from police and what their experiences are, and also I'd love to hear from EMS in Toronto also about the same thing. I agree with Mr. Bovey's statement and EMS's evaluation. We all are looking for a solution. Sorry, Mr. Chair, go ahead.
No, that's fine. I've had a quick little conversation with our CAO. She can make the ask to the Toronto Police Service.
That'd be great. And it's not a third party. I'd love to hear from them about not just the good stuff, but also the challenges that they face and what their learnings are. Because I think our outreach team is doing the same thing with the outreach teams in other communities. We're asking them directly. So.
And the CAO is taking it as direction.
Thank you very much. Thank you, Madam CAO. Mr. Chair, thank you.
You're welcome. Councillor Crawford.
Thank you, Mr. Chair. Very quickly, I just want to say that I am in support of this program. Maybe not as the way it was presented or from what we saw this morning, but I think that very similar to, sorry, I forgot your name already. Jeff was saying is that a Durham-made solution. And I also think that there has to be a certain amount of trust between EMS and police and who is being hired to basically, run the program. So I would love to see that all kind of work together before it's all separated into their own kind of pockets of where they fit in. Because I think that what Jeff was also saying was that he cannot hand down. Please, can you tell me what you said about that medicine thing? Yeah.
Through you, Mr. Chair. So if paramedics are already on scene, they cannot hand down to a lower medical authority. So if the team doesn't have a medical component to it, we face some pretty severe liability if we do leave.
Thank you. And I also think that we need to be working on a solution for people in mental health distress. So like the empath program is probably decades out there, but if we can somehow work together with this program and working and establishing something that we're actually going to be able to help people, having somebody respond that isn't able to take someone somewhere that they need the help for doesn't really provide a solution, right? We need to have a solution for that. This is like this. I still have 3 minutes. Okay. So this is provincial, like we always say. It's healthcare. Mental health is bigger than it's ever been now, and it's hitting folks at a very young age. And so we do need to have something in place. We just need to make sure that we've got the right thing. I have concerns about the 911. And if I can just ask Stella, I'll never get your name right, if through you, about even an expansion of maybe 311. Is that something that we could look at? Anyway, maybe through the CAO.
I think the
We'll
CAO.
go through the CAO.
Yeah.
Sorry. We haven't actually researched that. I would have some concerns through 311, but if you allow us to take it away, we can look and see if it's been tested that way elsewhere. 311 addresses all the other regional business, and there's not necessarily the expertise there to do the triage function that would be necessary, but let us at least ask some questions and get a more wholesome answer.
Right. I think, I think anytime you're comparing us to Toronto, it gets the hairs up on the back of my neck because it's a whole different funding privilege.
Yes, and in defense of the consultant, which I know I don't need to do, she did reference models all over North America. I think the intent with Toronto is because we are neighbors.
Yeah. London has a really good program. We heard about it at the Homelessness Symposium. But anyway, I just wanted to, those were my comments. No questions, sorry.
Okay, thank you. Councillor Lee.
Thank you, Chair, and thank you for the comments previous. I agree with Mayor Carter. We should be getting a representative from Toronto Police, but I also think we should be getting a representative from the City of Toronto, of the people who run the program, so we can hear exactly firsthand from them. DRPS had some comments in their attachment. They primarily consist of communications, which is a logistical thing, but can also be worked out. And then just the impact of mental health itself, which is not wrong, but that doesn't, that still doesn't address the immediate need for first responders being unarmed, being specifically trained in this field. I think we often discount the intimidating force of a police force when someone's having an anxiety, depression, suicidal thoughts, and the impact that could have and the increase of stress because of that. That's why these programs exist all through North America. I think we would be doing ourselves a disservice. I guess ultimately, to sum up the DRPS concern of just like there's other mitigating factors in mental health, that's absolutely true, but the same is with crime. I think, we can't solve the whole problem when the immediate problem is facing us. And right now, we'll use Toronto statistics as the example. We can divert 13.5% of calls, ideally, and possibly even more, with a program like this. I would love to hear from Toronto, or even from our own police service, what is the, for lack of a better phrase, customer satisfaction after the police deal with a mental health call? And I don't know if we keep track of those stats, but there are people like, oh my goodness, thank goodness DRPS was there. They really handled the situation properly. Or could it be there's room for improvement? Because if the majority of people who call DRPS for mental health issues say there's room for improvement, then that is what this program is built for. So I'll leave it at that. I think ultimately there's, concerns from all parties regarding the money involved, where the money goes. I think this is a really progressive option that is, still in its early infancy, that's going to constantly evolve. And I think it's going to be the norm, my guess, across North America, across the world, in how we deal with mental health crises and first responders. Thank you, Chair.
Thank you. That exhausts the list. We'll call the vote. All those in favor? In opposition? Seeing none, that carries. Mr. Clerk, we will move on to item 7.6, the request for funding from the Central Lake Conservation Authority.
clarification. The vote that we just did,
Was
it's in our report, it says receive for information. So we vote, we receive for information. What, is there going to be action taken now, or what's happening with this?
Well, part of it, there was direction given to the CAO to regain some information from the City of Toronto.
Oh,
Police
that, yeah. But outside of that, is that where we are now?
We will certainly take care of that and try to get it at an upcoming committee of the whole meeting. We also plan to report back later in the year with respect to how pilots could be structured within the region. So you will actually see that coming before the end of the year.
Okay, thank you, sorry.
No problem. So on the next item, the Chair Cloca, Mayor Roy, will you move this item, please? Seconded by the Vice Chair Cloca, Councillor Chapman. The item is now on the floor. Mr. Clerk, I see none. I'll call the vote then. All those in favor? In opposition? Seeing none, that carries. The last item in your agenda is on page 299. It is the request for funding for the Central Lake Conservation Authority acquisition of land. Mayor Roy, as the chair, Councillor Chapman is the vice chair. So the item has been moved and seconded. It's now on the floor. Okay, Mr. Clerk, I see no hands or nothing on my screen, so I'll call the vote. All those in favor? In opposition? Seeing none, that carries. There are no confidential matters. Last piece business of the day is adjournment, Mr. Clerk. Looking for Councillor Shahid, seconded by Councillor Kerr, on the motion to adjourn. All those in favor? In opposition? Seeing none, that carries. Thank you very much to members of council and staff today.